Hello guys, welcome to our channel. Today we will be discussing the medicine part 2. In the part 2, as I said, I am going to discuss about the rheumatology, cardiovascular, ECG, respiratory and the renal. Okay, all the miscellaneous topics also we'll be discussing here. So this part is very important because cardiovascular questions can be innumerable questions can be asked us. So should not be ignored and you have to read this no matter what. Let's start the discussion, guys. Those who are new to this channel, please do subscribe and share with your friends, and also please do like the video so that the algorithm will show the other students who is preparing for the upcoming examination and it will be helpful for them. So let's start the discussion, guys. So if you want to have the book, you can just join the Telegram group and text me from there and we will let you know the details. And so I want to just introduce the two most influential persons of my life within the medicine. So medicine is one of the hard subjects, but these two people have made me most easy. So this is the doctor. So this is the whoever is watching from my alumni will be getting to know. This is the Dr. Rakit. She is an internal medicine cardiologist. So one of the best faculties. She is like a walking library of the medicine. I always have inspired by her teachings. So another one is that Dr. Nazim is a well-known educator of the MBBS classes and the USMLE classes, and he is also one of the most influential persons who has changed the entire courtesy of the understanding for the MBBS and the classes, right? So these are the one of the two influential persons that I have wanted to share with you guys. So let's start the discussion without the delay. So first we will be discussing the basics. So what is the importance of the system that we have to learning today? So the first thing that you have to learn is how the normal physiology works. So normal physiology, which will be supported by the atrial systole, followed by the ventricular systole and the diastole, right? So contraction, relaxation, relaxation. So this is a vicious cycle that is going in our body. So how this is going to happen? First, we have the atrial contraction. So all the atrium valve, if you can observe, this is a small atrial valve which is going to contract to push the blood from the atrium to the ventricle. So through the ventricle, that is going to happen. So after the atrial contraction, we will be having the isovolumetric contraction. So this is a isovolumetric contraction. What is mean by the isovolumetric contraction? All the valves, okay, all the valves are closed at this point. Nothing is open, all the valves is closed here. So after closing here, so there is a pressure that will increase and the volume is low, but the pressure is increased. How much pressure? 120 mmHg pressure is increased. So this pressure which will lead to the rapid ejection. Okay, so the blood will be pumped out. So this is the main event of the systole. So rapid ejection is seen. So at this point, exactly before the rapid ejection, so there is a two valves that is going to open. Aortic and the pulmonic valve is open here because ejection means blood has to go out. So aortic and the pulmonic valve will be open, and simultaneously we will be having mitral and the tricuspid closure because we are preventing the regurgitation. So this has to be closed. So this closed sound which will generate us S wave S1, that is a S1 closed sound is the first hard sound we are going to get, and after that some point majority of the volume is went. So the pressure here is decreasing here. So the pressure will be decreasing and this will cause the slow ejection. This will cause the slow ejection. And all this event, okay, all this event is considered as a systole. This is considered as a systole, right? Next, continuation to the systole, we are moving on to the diastole. So let's see how the diastole is working. So when I say the diastole means the relaxation, it has to be filled. So isovolumetric relaxation. Again, isovolumetric relaxation means the pressure here is decreased, volume is here high, and all valves is closed at this moment. All valves are closed. No movement is happening. So after the relaxation, when the volume is expanded, so this will cause the rapid filling. So this will cause the rapid filling which will be happening here. So rapid filling means valves is closed. We have to open, right? Again, at this point, two valves will be opened here. Tricuspid and the mitral valve will be opened to fill up. So that is what happening here. Okay. Next, another two valves has to be prevented to overflow. That is the aortic and the pulmonic, which will be closed, which generates the S2 sound that is heard at the rapid filling stages, right? Next, followed by the slow filling, and diastasis. What does mean by the diastasis? Diastasis means at a time all pulling into the same place, that is known as a diastasis. So there is a slow filling. So all these events is considered as a diastole. This is considered as a diastole. So this is the pattern that we have, systole and the diastole. So this is the most important cardio cycle that you have to take note. And how you are going to plot this on the graph. Okay, how you are going to plot this. So this is the pressure axis, this is the volume axis. So in this both we are going to take note. First, let's start the depends on the value. So at the end of the relaxation, how much we have? At the end of the relaxation, we have 40 ml. Okay, we have the 40 ml only after the end diastolic value. So here the mitral valve is opening so that the filling will be happening. So we have filled a maximum 120. We have filled a maximum with the volume of the 120. After this 120 ml as filled, so what happens? There is a contraction that happens. So pressure is raised, right? Pressure is raised again. So this pressure is raised. The patients will open to aortic valve opening. So this will cause the systolic ejection, right? This is going to cause the systolic ejection. And to prevent the dysystolic ejection, we have to close the aortic valve. And after that, complete ejection is completed. What happens after the ejection is completed? The pressure is decreased here. So that will cause the isovolumetric contraction. Sorry, isovolumetric relaxation. And the two events that you have to remember, first, this is the A point, this is the B point, C point, and the D point. At the D point, we have the S2 sound. At the AB point, we have the S1 sound. So this is how we are going to plot the patients, whoever is having this, if they want required for the uh, filling and the pressure and the values that we are going to decide, right? This is how we are going to decide the pressure and the volume graphs, right? And depends on this only, I'm going to tell you guys how we are going to interpret the murmurs. Okay, we will be discussing that, but remember this important concept. Next, cardiomyopathies. Cardiomyopathies, why it is called the cardiomyopathies? Because the cardiac muscle is proliferately, or it is going into the irreversible damage. That is what cardiomyopathy. So most commonly, as a classification, we have three types: dilated cardiomyopathy, hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. So let's start with the first one. Dilated cardiomyopathy is overall the most common. This is the overall most common one. And the cause is most commonly in India. In India settings, I am talking about, this is the alcohol. Okay, most commonly in India, it is alcohol, followed by the genetic. And in the genetic, there is a protein that is deficient. Titin deficiency is seen in this patient. And whoever is suffering from the Duchenne muscular dystrophy, Becker muscular dystrophy, and patients who is taking the smoking, patient who is taking prone for the cocaine, and selenium deficiency, magnesium deficiency, thiamine deficiency, okay, B1 deficiency. And also some of the conditions like viral pathologies can be caused, coxsackie viruses can cause, and pregnancy peripartum period can increase these chances. Sarcoidosis can cause this, okay, and also hemochromatosis, iron overload, this condition can also cause. This is a patient which will be suffering from this multiple conditions. This can be caused by the dilated cardiomyopathy. So how does the dilated cardiomyopathy will be looking like? So this is a symmetric, this is going to be the symmetric left ventricle, and the right ventricle is dilated. And how about the movement? The movement is decreased because when the volume is more expanded, it can't be movement is not that much. So it is a hypokinetic. And whether if it is a hypokinetic, the movement is not happening, the pumping is not happening. So what happens here? So there is a reduced perfusion, right? So the patient will be having the reduced perfusion, and this can lead to the patients with the heart failure with the reduced ejection fraction, or also known as a systolic heart failure. So these patients will be going into the systolic heart failure. So here you can see, so completely there is a dilatation of the heart. So this is what the dilatation and thinning. So this ventricle is does not look like this much thin. So this is what the enlarged ventricles thinned after this condition. And what is the treatment? And if you can observe, all are the secondary causes only. So there is only the titin deficiency is the primary cause. We can go for the transplant, and remaining all, what we have to do guys, we have to treat the underlying cause. Treat the cause. That is the foremost important part of the dilated cardiomyopathy. Next, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a severe condition. Why it is a severe condition? Because it is 100% it is a genetic condition only. There is no secondary causes. The most common any entity that involves the heart with the genetics, that is the hypertrophic cardiomyopathy only. And these patients is having the defect in the bifibril bifibril myofibril, okay, that is deficient in this patient. Okay, that is the one thing that is deficiency. And symptoms, the patients will be having the dyspnea. Why the dyspnea is happening here? So heart has to pump, right? If they can't pump, there is no perfusion, so the patient might feel the exhaustion and the dyspnea is seen. And again, pumping is not happening, so again there is a chest pain which will be presented in this patient. And most of the times, unfortunately, the this condition is 50% is asymptomatic. So the patient will be asymptomatic, we doesn't even know. So these asymptomatic patients, if they are not diagnosed, what happens? Over the time they can develop the hypertrophic obstructive cardiomyopathy, which will be causing of the sudden death. Okay, which will be causing the sudden death in these patients. And on the physical examination, you are going to feel the jerky pulse. You are going to feel the jerky pulse. And also there is a murmur which will be occurs in these patients. And murmur is especially when there is a systolic. Okay, this is known as a systolic murmur. And along with that, you will be having the pulses differences. These pulses differences is known as a bifurence pulses differences. And on the echo, it is going to be asymmetric swelling. Okay, asymmetric type. And also the movement is hyperkinetic. So if it is a hyperkinetic activity, it's heart failure with a preserved ejection fraction and diastolic failure that you are going to see. Diastolic heart failure which will be considered in these patients. And the treatment is mostly myomectomy. Whatever the extra you have to remove. Sometimes we can go for the ablation using the alcohol. Using the alcohol, you can go for the myomectomy, and beta blockers also can be used for these patients to treat the underlying causes of the symptoms. Beta blockers also used. Next, restrictive cardiomyopathy. So restrictive cardiomyopathy is a condition where there is a buildup of the different systems like amyloidosis. Okay, this amyloidosis is going to restrict. It does not going to make it move of the restrictive cardiomyopathy. It's going to be the fibrotic, very hard of the heart to be stiffened. It cannot pump. And who is suffered for the thoracic tumors, so who has to go for the radiation like the breast cancer patients also. And it could be due to LSD, lysosomal storage disorder, glycogen storage disorder, or again sarcoidosis, again it can enter here, and the hemochromatosis. But if you see these two options in the dilated, you can choose that also, and same as the restrictive also. And the echocardiography, under the echocardiography you see there is no movement at all because it is completely stiffened, akinetic movement. And it is also asymmetric. It is also asymmetric. And the patients will be having the biventricular failure because 2 is not pumping. Okay, biventricular failure is seen, but mostly diastolic failure followed by the systolic. Again, the treatment here is the treat the cause. Treat the cause. But most of the time I said myomectomy is possible, but best treatment for these patients, it is transplant because it is a genetic condition. Even if you do the myomectomy, obviously there is a again growth will be seen, right? So that is why we are going to move for the complete myomectomy has to be done for these patients. Next, coming back to the another type, this is a very rare type, most commonly seen with the Japan people. So that is why the name is also Takotsubo cardiomyopathy, which is also known as a stress cardiomyopathy or the broken heart cardiomyopathy. Okay, broken heart cardiomyopathy. Rarely we see in India this kind of cases, but Western countries more emotional, in India less emotional. So that's why we don't have the broken heart syndrome. So what happening in the broken heart syndrome? Whenever the patient is having the stress, Okay, let's say some person is died. So what happens, this person will be having the sudden sympathetic activity is raised because of the tension, anxiety, unfortunate incident that the patient is came to know. His stress is going to increase the sympathetic activity. Okay, he will be increasing the sympathetic activity. So what happens once the sympathetic activity is increased? Obviously the norepinephrine and the epinephrine is also going to raise. So these norepinephrine and the epinephrine will increase the BP, will increase the cardiac output. If you want to increase this, you have to make the heart to have the movement. Okay, so the heart will be having the complete kinetic movement. Okay, hyperkinetic movement. So these hyperkinetic movement of the heart will going to cause the muscle involvement, and all the ATP is consumed. So all the ATP is consumed here. Once the ATP is consumed, once the ATP is depleted, what happens? Wherever there is a thin, for example, this is the heart, right? So here we have this like, so this is ATP is depleted. So this is the thin layers, right, on the basal sides. So suddenly that is going to converted as like this. So there is an inward ballooning. So that is what seen in the patients of these conditions. So once there is a kinetic movement which will be reached due to the patient's ATP consumption is done. So this is also known as a apical ballooning. Apical ballooning. But these patients which will be presented with a chest pain, okay, and also patients will be presented with the ECG, ST elevations, okay. Sometimes even troponin is also elevated, but immediately you have to don't jump for the diagnosis whenever you see this condition, because they don't tell the as much as the chest pain that the patient will tell with the MI. So that is the differentiating feature, and that radiating pain is absent here. So that is also another clinical sign. So when you see the echo, on the echo is the best diagnostic method. So on the echo you are going to see this apical ballooning. Apical ballooning is seen in this patient. First, the treatment has to be stabilize the patient, followed by the ballooning. Okay, you can just send the through the catheter, ballooning has to be sent, and with the help of the ballooning you can go for the dilation of the apical ballooning you can go for. This is what the Takotsubo cardiomyopathy that we had. Okay, next, so we will be discussing of the very miscellaneous topics but very important topic. So that is the Prince metal angina. So Prince metal angina is not a real angina. It is a pseudo metaphor. This Prince metal angina is actually vasospastic condition. Okay, vasospastic condition. So what I mean for the vasospastic conduction, usually our vessels are like this. So in these conditions, what happens? The vessels are so thin and becomes narrow. Okay, this narrowing is called as a vasospastic condition. It's kind of like a vasoconstriction only, but there is a spasticity. Spasticity means the movement is vigorous, but it is constricted. That is what the Prince metal angina. Obviously, the patient will be having the symptoms of the chest pain because the blood vessels, the blood flow is decreased, right? Oxygen demand is raising, so that is what the patient will be presented. But the troponins is going to be normal, and also ECG changes will be normal. So what is the treatment for this patient? Beta blockers. So here the making the mistake. Beta blockers is contraindicated in patient. So CCBs is a drug of the choice for this patient. That is a Prince metal angina. Next, see the real ischemic heart disease. Okay, this is a real ischemic heart disease that we are going to look after. So ischemic heart disease is going to be the acute condition, or it could be chronic condition. Chronic condition, this is a stable angina. Okay, this is the stable angina, and here it is the unstable angina. Okay, but in India we have the silent angina. This is also known as a silent MI. Whoever is suffering from the diabetes mellitus uncontrolled, they can go for the silent MI within the early mornings of the period because of the adrenergic activity, because they don't feel the pain because of the neuropathy and the complications of the diabetes mellitus, so they can die with the silent MI. And whenever you see this patients who is suffering from the ischemic heart disease, what is the most common cause? The most common cause is the ischemic heart disease, right? Ischemic heart disease. But how this ischemic heart disease is presented? Because of the atherosclerosis. Because of atherosclerosis, right? And atherosclerosis followed by the smoking in the vessels. atherosclerosis and the followed by the smoking. And atherosclerosis which involve the LADA, left anterior descending artery. This is the most common artery that is involved. And the least common artery, that is LCX. Okay, that is a left circumflex artery, that is a very rarely is seen. Next, differentiating features that you have to take note about the stable angina and the unstable angina. So as I said, stable angina is a chronic type, okay, and the unstable angina is going to be the acute type. So why it is? So the patients, whoever is suffering from the angina, means the pain is present for these patients. So stable angina patients, when they are doing the exertion, so the pain is present, okay, but by the rest of the it will be decreased. Or when they take the nitrates, so this is going to decrease. So this is the stable angina, and they are producing it to the chronic. It is not a chronic, they are actually prolonging with the rest and the nitrates. And here unstable angina, this is going to start on the exertion, obviously, and when the patient took the rest more than 10 minutes also, still the pain is present, and the patient has took the nitrates, one dose may decrease, but actually after the over the nitrates also the pain is still present. So this is known as a unstable angina that the patient is had. So unstable angina, not just they need the nitrates, sometimes they need the oxygen also, and sometimes painkillers also. Even if needed, if it is progressed to the NSTEMI, they need immediately intervention has to be started for these patients. So that is what the difference between the mainly the stable angina and the unstable angina. So next, moving on to the another entity. Let's say that the unstable angina has developed to the NSTEMI. Okay, NSTEMI has been already developed for these patients. What we have to treat for these patients? First, you have to order the ECG. On the ECG, you have to see what are the changes. Most commonly, the first will be T inversion will be seen, and the non-ST elevation will be seen, non-ST elevation will be seen, and the ST depression. All this will be seen in this patients. And order for the troponins. Okay, troponins is normal, is not yet raised. So then this is a NSTEMI. The diagnosis has been started. So you have to give the treatment patients to the morphine, oxygen, aspirin because of the clot. You should not be forgetting that this can cause the patient severe condition, and the nitrates. Okay, so the MON, okay, MON, that is a mnemonic for the NSTEMI elevation. Next, so let's say the patient is developed the STEMI, okay, that means transmural, all the layers has been involved, and that is going to cause the necrosis, the tissue is going to die, and ECG is going to show you severe ST elevation, and sometimes the patient can have the bradyarrhythmias or the tachyarrhythmias. So this is a severe case, we have to intervene right now. Troponin has been sent, and troponin is also positive. Not only troponin, other also positive. What have to do for this patient? So treatment is simply PCI intervention or depends on the CAPG. Okay, we have to go for the intervention for these patients. And how you are going to treat these patients? So we are going to treat this patient. The PCI is the door to balloon time. Okay, door to balloon time. Door to balloon time means how many in within the how many minutes we have to start the treatment for this patient. We have to start within the 90 minutes. So the PCI intervention has to be started within the 90 minutes. If it is a PCI center, let's say this is not a PCI center, this is a non-PCI center, and how many time you have to take 120 minutes. That means you have to send the patients nearby PCI center and start the treatment. So first 90 minutes is the best option. If it is a non-PCI, 120 minutes we have to go for the patients. NSTEMI is also divided. If the NSTEMI is severe, if you see this is progressing, then we have to go for the, again, we have to less than 120 minutes, we have to start the patient with the PCI. But if the patient is moderate, we think that the patient might develop, then we can go for the thrombolysis as early as possible. Okay, thrombolysis can be done for these patients as a treatment. So this is how we are going to treat the ischemic heart disease and the types. Okay, as I just said now, the treatment that I discussed here, after that ECG, and the detailed ECG will be declared in the end of the lecture. Next, moving on to the hypertension. Hypertension has a different classifications. Fortunately, in the examination, we have not been seeing with the hypertension classification, but the basic thing that you have to take note, the Always normal is less than 120 and less than 80. The early stages which will be elevated more than 120 and more than 80. And high blood pressure, which is the stage 1, is more than 120, 130 or, okay, this is or more than 80 or more than 90. Which is more dangerous? Diastolic blood pressure raise is more dangerous than the systolic blood pressure. And the stage 2, which is considered as a more than 140 and the more than 90. And the hypertension crisis more than 180 and more than 120. Okay, so how we are going to treat these patients? Let's say the patient is less than 65 years old or the patient is more than 65 years old. Before that, all the patients is given as a beta blockers in India over the time. But we have changed the proportion for these patients. If the patient is less than 65 years old, you can go for the patients with the ACE inhibitors or the ERB inhibitors, okay, ERB blockers. Or the patient is more than 65 years, we are going to choose the patient with the CCB. Calcium channel blockers has to be given for these patients. But fortunately, most of the patients will be treated well. But if the 65 plus, still the patient is having the other comorbidities like a patient is having the diabetes mellitus, already previous MI, then we can go for the ACE inhibitors or the ERB inhibitors for these patients. So that can be also given for these patients. Next, coming to the urgency. Okay, what is the hypertension urgency? We just now discussed the crisis is more than 180 and more than the 120. But fortunately, this patient multi-organ dysfunction is not present. Only the BP was raised. So for this patient, we can go for the drug of the choice, oral drug. Okay, oral drug in the PHC settings or in the emergency settings, what we can give for this patient is the oral clonidine. Okay, but this is not a reality oral clonidine we are going to give, but oral clonidine is a drug of the choice for these patients. Next, emergency settings. Okay, patient is came with a hypertension emergency, and here the patient is having multi-organ dysfunction. What I mean for the multi-organ dysfunction, urine output is decreased, patient sensorium is lost, patient is have the syncope attack. All these are considered as an emergency, and for this patient you cannot give the oral because aspiration risk was high. So for this patient you have to choose the IV drug. And what IV drug we can give? We can give the CCB, and the choice for the CCB is a nicardipine. Okay, nicardipine, card. So this is for the cardiac cause that we are going to give for the patient as early as possible. Next, resistant hypertension. What is the resistant hypertension? So resistant hypertension means I have already started the patient on other drugs. For example, I started the patient on the CCB, I started the patient on the ACE inhibitors, two drugs I have added, plus or minus. I also added the diuretics. Okay, I also added the diuretics. For example, thiazides. Still the patient is uncontrolled hypertension is seen in this patients. What I have to do?
These are
First
the
thing, the
important
most
points
important one
and
is
the diseases
whenever
that
this
we have
elderly
to
people,
remember
we
in
give
this
multiple
condition.
drugs also.
Those who are new to this channel,
Incompliant,
please do
they
subscribe.
don't take. Okay, that is the primary cause. Okay, but if it is still not considerable, then there is a cause that is comes here. That is a endocrinopathies. Okay, endocrinopathies, hypothyroidism condition maybe, Cons syndrome, adrenal causes, pheochromocytoma, or the patient is having the obesity. All this is considered as a endocrinopathies, or the patient is having the renal artery stenosis. This condition can be seen. So these are the causes of the resistant hypertension, and the treatment here is the spironolactone. The drug of the choice for the resistant hypertension is the spironolactone. Next, malignant hypertension. What is the malignant hypertension? So the malignant hypertension is going to cause the primary sclerosis. Okay, primary sclerosis in the vessels with severe hypertension. That is what the patient suffering from the primary malignant uh, malignant hypertension. Next, we also have the hypotension. So we discussed already hypertension, but how you are going to treat the hypotension? Hypotension, when you say SBP, SBP is 20, less than 20, or the DBP less than 10. So for these patients, we are considered as the hypotension, and the cause is autonomic dysfunction. Okay, autonomic is the most common dysfunction that can cause. So drug of the choice for this patient is the midodrine for the over the time. But treatment of the choice on the settings, when you see the patient, you have to give the IV fluids. Okay, IV fluids has to be given for the patients. But the over the time course, then you have to choose the midodrine as a option. All right. Next, coming to the heart failure. What is heart failure that is going to seen in this patients? Whenever there is a pressure overload, we all know Frank Starling law. More you pump, the more it will be stretched. But over the time, if there is an overload, what happens? While stretching, it can develop the hypertrophy. And this hypertrophy can go into the ischemia. And ischemia can cause the DNA damage. And all the important vessels, products, and the growth factors will be decreased. So it is going to either it going to cause a compensated heart failure or it can cause the decompensated heart failure, which will be seen. And the decompensated heart failure, which is a low ejection fraction, that means reduced ejection fraction, which is seen with the systolic, okay, or the right heart failure we are going to see. And compensated heart failure, the ejection fraction is maintaining still. So this is the diastolic heart failure or left heart failure that we are going to see in this patient. Let's see the difference here. So right heart failure and the left heart failure. Okay, what happens here? So whenever the patient is having the right heart failure, so the ejection fraction is decreased, it is reduced. And left heart failure, the ejection fraction is still preserved. So this is going to be the preserved ejection fraction. And this is the systolic failure and this is the diastolic failure. So what is the symptoms that is going to be presented in this patients? Right heart failure. Right heart is not able to pump. So it is going to send back to the atrium itself. So it is going to cause the JVP raise. If the JVP is raised, it is going to back to the intravenous inferior vena cava or the superior vena cava. So the patients can have the hepatomegaly because the blood is going back pump and the patient can form the anasarca. Okay, this is the right heart failure that we are going to see. And the left heart failure, again, that is not pumping, so it has to go to the left atrium to the pulmonary. So the patients can develop the pulmonary edema. So they can develop the pulmonary edema. And if the patient is having the pulmonary edema, patient will be having the symptoms of the cough, patient will be having the dyspnea, paroxysmal nocturnal dyspnea is seen in this patient. Orthopnea, as per the position, will be seen in this patient. All these symptoms will be seen in the left side of the heart failure that we are going to see. So this is the major difference between the left heart failure and the right heart failure that we have seen. But what is the most common cause for these patients? So the most common cause for this patient is hypertrophy, and the hypertrophy is more prone with the hypertension, right? Hypertension patients can develop this heart failure and many other causes, but the most important cause is the heart failure that is associated with the hypertension. And how we are going to treat these patients? So the treatment of this patient is depends on the patient presentation. So most of the times what happens in the heart failure, let's say the patient is having the heart failure, that means volume is overloaded. Okay, volume is overloaded. So this volume overload cannot be pumped by the heart. So eventually the cardiac output, the BP will be decreased in this patients. But whenever we have the BP decrease, what it is going to have? So it is renal blood flow is decreased. That means renal perfusion is decreased. If the renal perfusion is decreased, it is going to activate the renin. It is going to activate the renin, and the renin will increase the aldosterone secretion. What does the aldosterone will do? It is going to retain the sodium and also it is going to retain the potassium, sorry, retain the H2O. And aldosterone is also going to cause the vasoconstriction. Vasoconstriction will be seen with this aldosterone. Next, whenever the renal blood flow is decreased, it is going to activate the aquaporins. Aquaporins means ADH-V2, and this will cause the thirst, first point, and this will also retain the water back, the main function itself retention. So H2O is more retained here. Again fluid overload that will be seen. And other V1 is generated, then it is going to cause the vasoconstriction. So like this, in number of the factors, all are affecting the heart failure, further worsening only. But when you have this fluid overload, okay, so this fluid overload will also activate the natriuretic peptides. Okay, one you have brain natriuretic peptide and also atrial natriuretic peptide. What does this natriuretic peptides will do? So this will be activating the natriuresis. Okay, natriuresis. That means sodium and the H2O is sent via urine. So that is what the natriuresis somewhat overload which will be decreased by this particularly heart failure. Okay, and how we are going to treat these patients? So the treatment coming to these conditions, we have divided it into the two types, acute and also chronic. So acute patients, what is the most common acute cause? Acute cause is the compensated only. Okay, acute cause will be compensated, left heart failure. So for these patients, diuretics should be given. Okay, like furosemide to decrease the pulmonary edema for these patients, and also beta blockers, ACE inhibitors can be given for these patients, and ionotropes. Okay, ionotropes like dobutamine and the furosemide is given for this patient. And the chronic is always uncompensated. The patient is already in the severe stages. So for these patients, again we can go for the beta blockers, ACE inhibitors, and the herb drugs can be given for these patients. Diuretics can be given for this patient, and we also have to give ANP increasing drugs. ANP increasing drugs means nephrolysine. This is the nephrolysine, which the drug that name is known as a sacubitril. The drug can be given for these patients, and along with sometimes digitalis can be given to decrease the contraction of the patients, and remaining other ivabradine and hydralazine, these drugs can be also given for these patients. So this is how we are going to treat the heart failure patients. And sometimes you can decrease by giving the SGLT2 inhibitors, because SGLT2 is going to send the whatever the fluid that is present in the body. That also we can do. Next, moving on to the another condition, that is the valvular lesions. Okay, so you can see this is the how the valves will be looking like. Most of the valves will be the three leaflets that is presented, and the pulmonic valve and the tricuspid valves, these are known as a cusps. Okay, these are known as a leaflets. Okay, there is a one and two leaflets here, one and two leaflets for the aortic. So three cusps and three cusps for the pulmonary and the tricuspid valves. So let's see how we are going to differentiate these conditions. As I just discussed here, coming back here, so what I discussed, there is a systolic phase, there is a diastolic phase, and there is a openings, there is a closings of the valves. Just to summarize here, let's once again we will be summarizing here. So isovolumetric contraction followed by the isovolumetric relaxation, and again back to the cycle, isovolumetric contraction. So in the isovolumetric contraction, what are the valves is that is opened here, guys? Mitral and the tricuspid valve is closed here. Okay, and pulmonary and the atrial is open, same as here. So it is completely opposite. Mitral and tricuspid is open, and the pulmonary and the aorta is closed, right? So whenever the closure, we are going to have stenosis. Okay, so whenever there is a closure, what happens? So the patient will be having the, sorry, whenever the valve, for example, this is the valve that is closed, tightly closed, but still the blood is coming. Okay, blood is coming. So this is what the regurgitation. After closing, there is a regurgitation. And next, opening. Opening is narrowed. For example, only the minor is opened, all is closed. So this is what stenosis. This is stenosis. So now tell me whichever is going to present here. So patients who is having the systolic murmurs, okay, this is the systolic murmurs, and this is the diastolic murmurs. So mitral, how the mitral is closed? So mitral regurgitation, and all the mitral regurgitation is systolic, and tricuspid regurgitation. Pulmonary is opening, that means narrow opening, pulmonary stenosis, aortic stenosis. So these lesions is going to have the systolic murmurs. Okay, again revise with me. Mitral regurgitation, tricuspid regurgitation, pulmonary stenosis, atrial stenosis will have the systolic murmurs. Why? Stenosis means narrow opening. Which valves is opening in the systole? That is a pulmonary and the atrium. Which valves is closing, which is going to cause the regurgitation? Mitral and the tricuspid. Opposite to this, once if you remember the systolic, opposite to the systolic, we have the mitral stenosis, tricuspid stenosis, pulmonary regurgitation, and the aortic regurgitation. Simple, your murmurs is done. Right? This is the simple murmurs that you can remember. And the one murmur that you have to remember here is the mitral valve prolapse. That is also systolic murmur. These are the systolic murmurs and these are the diastolic murmurs that you have to remember. Okay. Next, coming to the another important points one by one. And I'm not going to discuss all the types, but some points that we will be discussing now. For example, let's say the patient is having the aortic stenosis. Okay. The patient is having the aortic stenosis. The most common cause for the aortic stenosis is aging. Okay, you might be get, I might be get after we get the more than 60 years. So aging is one of the factor for the patients who is suffering from the aortic stenosis. Why the aging is a play the major role? Because at the aging we may develop the atherosclerosis. So all the valves will be involved in the atherosclerosis. Even the vessels is involved in the atherosclerosis. Or whoever is suffered from the RHD condition can be associated with this. And most of the times aortic stenosis. What does mean by the aortic stenosis? That means your cardiac output and your end diastolic and systolic value that is decreased in this patients. So the cardiac output will be decreased in this patient. If the cardiac output is decreased, the patient can have decreased BP and this can cause the syncope in the patients, and also it can cause the pulmonary edema because of the hypertrophy, and also this can lead to the dyspnea in the patients, right? And cardiac output is decreased, it can cause the pain because of the muscle is not getting, that can cause the angina pain. Okay, all these symptoms will be seen in this condition. And what is the treatment? All the treatments of the valves that you have to remember, there is going to be the valve replacement is the only surgery that we are going to do for these patients. But another point that you have to remember is diuretics is contraindicated in these patients. Diuretics is contraindicated in these patients. And other features you can remember, this patient will be having the pulses tardae. Okay, pulses tardae which will be presented. And the murmurs, what is the aortic stenosis murmur, guys? It is a systolic murmur, but it is going to look like this, diamond shaped. So we call this as a crescendo decrescendo murmur. Okay, this is a systolic murmur. So this is the feature of the aortic stenosis. Next, aortic regurgitation. Okay, in the aortic regurgitation, the patients will be most commonly, this is due to hypertension, okay, valve damage, or the patient who is suffer from the rheumatic heart disease. They have some of the important features, okay, important features that you have to remember with the aortic regurgitation. Water hammer sign. Water hammer sign. So water hammer sign is known as a collapsing pulse. You can't feel the pulse regular, the pulse is collapsing. That is a water hammer sign. Next, Corrigan sign. Corrigan sign is the carotid arteries. The pulse which is coming from the carotid artery, it is only palpable, but here it is visible. Here it is visible. Next, pallor on the head. Pallor on the forehead. So this is seen in the lighthouse sign. Lighthouse sign. So these are the some of the important signs that you have to remember. Only this is the points, and it is a diastolic murmur that we are going to have. And the name of the murmur is the Austin Flint murmur. Austin Flint or early diastolic murmur. Early diastolic murmur. Two important points that is easy to remember, I guess. Right? Next. Next, we will be discussing of the mitral stenosis. Mitral stenosis. So mitral stenosis patients, the most common cause you all know, this is a rheumatic fever which develops the rheumatic heart disease for the patients, right? So mitral stenosis, again the pumping is not problem. So cardiac output is decreased, same as the BP is decreased. Patient can have the severe conditions. So when the mitral valve is not opening properly, this patient can have the atrial dilatation. So this atrial dilatation will compress the right laryngeal nerve. This right laryngeal nerve, if it is compressed, this is known as a Ortner syndrome. This is known as a Ortner syndrome. And the patient will be having, again, the patient will be having the syncope, right? Fatigue, fatigue is seen, and also hoarseness because of recurrent laryngeal nerve is involved. Hoarseness will be seen in this patient. Next, coming to the treatment, again, stenosis patients, diuretics is contraindicated. Okay, diuretics is contraindicated in this patients, and the murmur is diastolic murmur, right? Mitral valve is open set diastolic, so this is a diastolic murmur that we are going to see. So these are the some important points that you have to remember. Next, coming to the mitral regurgitation. In the patients who is suffering from the mitral regurgitation, these patients is again developed by the rheumatic heart disease. This is also rheumatic heart disease patients. These patients will be having the heart failure symptoms more prominent. So heart failure symptoms like dyspnea is seen in these patients, palpitations is seen, okay, palpitation is seen because the blood is coming back. So if the blood is coming back, the left atrium can't hold this, so it is going to pump back. So pulmonary edema, all this will be seen in this patients, right? So the murmur here is the pansystolic murmur, pansystolic murmur, okay, and also along with that pseudo pulse, okay, pseudo pulse. This pulse is also like a collapsing pulse that will be present in this patient, right? Another important point. Next, we also have the tricuspid stenosis and tricuspid regurgitation. So what is this both? It's a simple conditions, not most of the times is asked because very rarely is presentation of the patients. Cause is simple, rheumatic heart disease. Causes rheumatic heart disease, and JVP findings is play the major role here. So tricuspid stenosis patients, the JVP is going to show the Canon A waves. Okay, this is going to show the Canon A waves. Tricuspid stenosis, again it is a diastolic murmur. Next, tricuspid regurgitation, these patients JVP will show the X descent which is absent. X descent is absent. So that is what's seen in the tricuspid regurgitation. And another sign is the Lancisi sign. So what is meant by the Lancisi sign? The JVP is raised, and also carotid pulse is raised. All this will be feature of the Lancisi sign. That is what Lancisi sign we are going to see in this patient. And the murmur is systolic murmur. Next, last two, that is associated with the pulmonary stenosis and the pulmonary regurgitation, right? Pulmonary stenosis patients, we all know this is common with a Noonan syndrome, right? Noonan syndrome patients will be having this one, or carcinoid syndrome. Carcinoid syndrome is an acquired cancer. For the patients also, this is the cause that is associated, and the pulmonary regurgitation is actually associated with the hypertension and the rheumatic heart disease. And the special murmur that is present here is the Graham-Steele murmur. Okay, Graham-Steele murmur, also a type of diastolic murmur. Okay, diastolic is a type of murmur. Next, another picture that we have is the mitral valve prolapse. Mitral valve prolapse. In the patients of the mitral valve prolapse, how these patients will be presented? So the mitral valve prolapse, the most common cause is the myxomatous degeneration. This is consisting of the myxomatous degeneration, followed by the Marfan syndrome patients. Okay, followed by the Marfan syndrome. So the patients will be having the chest pain, which is atypical. Okay, the chest pain is not compulsory. We are going to rule it if that is a heart condition. So it is like a vague chest pain that the patient will be telling, and recurrent syncope attacks. So then we consider, okay, this is a cardiac cause. So when we check for the patients, there is a mid systolic click. First there will be a click followed by the late murmur, late systolic murmur. So for example, let's say this is the systole, there is a click and followed by murmur. So this is how the patient will be presented with the mitral valve prolapse. So okay, valve replacement is a treatment for this patient. So this is how we are going to check the patients, and this is the treatment that we are going to use for these patients, right? Next, coming back to the next topic is the rheumatology. In the rheumatology, you have to understand the most important topics are arthritis, SLE, and also some of the basic parts that you have to remember, guys. So in the patients with the rheumatology, osteoarthritis and the rheumatoid arthritis, they both are different. Okay, only the rheumatoid arthritis is an inflammatory autoimmune condition. Osteoarthritis is a not a autoimmune condition. Let's see the differences. This is the aging, or we can say this is due to degeneration. Okay, this is due to autoimmune and inflammatory. Okay, inflammatory condition. Next point, this is more seen in the elderly individuals. Okay, males are more prone than the females. This is more seen in the 30 years or the 40 years. More than 50, rheumatic fever, rheumatoid arthritis is not even seen. Females than the males, more common, right? Next, most common, the joints that is involved here is the dip joints. The most common here is the dip joints, and here the most common joint is the MCP joint, metacarpophalangeal joints, that is most common. And MCP is spared here. These patients have the spare. Here dip joints is spared. Here dip joints is spared. Dip joints is spared in this condition. So the patients on the X-ray findings, what happens? So the patients will be having the asymmetric, okay, asymmetric joint issues, such as there is a osteophytes is developed, osteophytes is developed, and space between the two joints is reduced, and the bones, that is sclerosis. Okay, so erosion, sclerosis, that will be seen in these patients, and the osteophytes are involved. Next, these patients which will be having classically Panus formation, and again here also the space is reduced and erosions will be seen. Osteophytes and the sclerosis is not seen in this condition, and it is symmetric. Both sides, both joints which will be involving. This is the symmetric joints, and this is increased by the work. The pain will be increasing with the work, and here it is decreased with the work. So that is the one differences that you have to take note. And Heberden notes, Bochard notes, I said in the pay in our orthopedics, and also other complications also I said in the orthopedics. Extra organs, null, nil, no involvement. Here extra organs are involved, especially subcutaneous nodules, or we call this as a rheumatoid nodules, and patient can have the uveitis and multiple other syndromes also seen with these patients. Let's see what are those multiple syndromes. For example, patient is associated with the most commonly uveitis, right? Uveitis with the patient is having the sclerosis, so that is going to have the rheumatoid sclerosis. And we also have the Felty syndrome. So what is meant by the Felty syndrome? Rheumatoid arthritis, pancytopenia, pancytopenia, and spleen is enlarged. Spleen is enlarged. Felty syndrome. Next, Kaplan syndrome. So what is a Kaplan syndrome? It is rheumatoid arthritis plus anthracosis, like cold workers pneumonia. That is also seen. So these are the two types. Next, we have the gout. Okay, gout. So first divide the gout: acute gout and the chronic gout. Both are due to uric acid. You here also uric acid, but the test here is a normal, here elevated. Okay, uric acid only involved in this both. And the joints, this is most common is the metatarsophalangeal joint, and here the most common is the knee. Okay, knee patients, and the treatment for this patient is the NSAIDs, like indomethacin can be given for this patient, and here the treatment will be allopurinol. Xanthine oxidase inhibitor has to be given for this patient. Next, we also have the pseudogout. So what is the pseudogout? Pseudogout is due to calcium pyrophosphate. crystals. And the most common is again knee here. The treatment is NSAIDs. And whatever the uric acid levels, obviously normal because it is a calcium related. So we can differentiate with the help of the microscopy. So gout will be having the urate crystals, and these patients will be having needle shaped and negative birefringence. Okay, needle shaped and negative birefringence that we are going to see in the gout patients. Pseudo gout, it is calcium related, rhomboid shape and the positive birefringence. Pseudo gout, positive refringences, calcium and the rhomboid shape that you are going to see. So this is what over just a glimpse of the gout that we have discussed. Next, moving on to the SLE. So SLE features itself. Here you can see how the patient is presented. Mostly SLE is treated in the females only. Males are rarely involved. So one in the world we can see the males with the estrogen. Males with the estrogen, when they take more estrogen, the SLE complications will be seen in these patients. But most commonly it is associated with the females because it is highly estrogenic condition. Whoever is having the more estrogen, they're going to develop. So type 3 hypersensitivity reaction, this is a type 3 hypersensitivity reaction. Patients involves every organ coming from the mental to the joints and the genitals and the ulcers, every part is involved. Cognitive dysfunction, seizures, alopecia, pleuritic chest pain, immune complexes, blood clots and anemia, inflammation, arthritis, heart murmurs, and butterfly rash, swollen joints. All this will be included in this patients, right? So this is the generally the patients which will be presented with the condition of the SLE, right? These are the symptoms that you have to remember. But you have to remember the antibodies. The antibodies questions can be asked. So the most sensitive and the most specific are going to be what we have to differentiate. So Anna is positive for the most sensitive, which is common for every other also. And the most specific is the anti-Smith antibodies. If you want to check for the progression and the treatment, then this is the anti-DNA double-stranded antibodies. Okay, this is for the progression type. If it is a drug-induced lupus, then you have to check for the anti-histone antibodies. This is for the drug-induced type. Okay, drug-induced lupus, and this is for the treatment and progress. That is we are going to check. But every system is also present. For example, heart blocks in the children due to mother. This is due to anti-Roe and anti-La. This is a recent INCT question. Okay. Next, if it is due to abortions, so the patient is having the APLA associated antibodies. APLA associated means cardiolipin antibodies that will be presented. If it is a CNS manifestations, so for these patients you are having the anti-neuronal or anti-ribosomal that will be presented. Okay, so these are the antibodies that is most importantly asked in the examination, and along with that the drug of the choice for this patient is hydroxychloroquine, but it has a side effect that is asked, that is ophthalmopathy bullous ophthalmopathy. How these patients are died? So this patient is usually died with infections followed by the coronary artery disease. Okay, most of the times will be infections only. That is how the patients will be dying. Next condition. So by the picture itself, you can understand the patient is having the ankylosing spondylitis. What does mean by the ankylosing spondylitis? So the spine has this kind of structure. But if there is an inflammation and if it is causing the fibrosis or the bone and bone is combining, so without the bulge, so that is going to cause the ankylosing spondylitis patients. So this patient is most commonly males, okay, with 20s or 30s age. This is the decade the patient will be having HLA B27, which will be positive in these patients. This is the feature, and this is seronegative condition. Seronegative condition this patient is having, where the patient will be associated with the morning pain. Okay, the pain will be morning, and with the help of the rest, the pain will be subsided. Okay, so the pain will be increased by the wakefulness. With the rest, the patient will be having the decreased pain. So most common joints that is involved here is the sacroiliitis, and it can cause uveitis, it can cause enthesitis. Okay, all this will be a features of the patients who is suffering from the ankylosing spondylitis. And what are the tests that we can perform for this patient is the scobar test. So in the scobar test, I will be asking the patient to bend forward. So when they bend forward, if the flexion is decreased, if the patient flexion is decreased due to the spine problem, so that is my diagnosis for the ankylosing spondylitis. Okay, that is a ankylosing spondylitis. And early stage, we are going to give the patients with the NSAIDs. If it is not controlled, then we can go for the DMARDs of the patients. And this is, here you can see what is the condition that you are seeing here. So this look like a bamboo, right? Bamboo. So this sign is known as a bamboo spine because of the fusion and the inflammation. Next, this is known as a, so this is the sacrum, right? So this is the sacrum. Okay, ilius bone is attached here. So this is known as a sacroiliitis, severe inflammation that is seen. So this is the some important points about the ankylosing spondylitis. Next, coming to the another picture that you can see here. So this is the scleroderma. So the patient here is suffering from the scleroderma. So what is the condition of the scleroderma? So it is also an autoimmune condition, and it is also going to cause the chronic inflammation in the body. Okay, first point. It could be diffuse, it could be diffuse, or it could be limited. Limited is classified as a crest syndrome. Limited is classified as a crest syndrome. Let's see the limited version. This is the crest syndrome. What is mean by the crest? C for calcinosis. The patient will be having the hardening of the vessels, and that is going to cause the hardening of the fingers. And Raynaud's phenomena. This is the pattern that you are going to see. Pale color and again circulation back because of the nail capillaries is dysfunction in this patients. And E for esophageal dysmotility. Again, the fibrosis is causing the dysmotility. Scleroductile hardening, and again telangiectasia that is seen in the patients with the hands. So this is what the crest syndrome. And the crest syndrome, what is the uh, antibody that is positive here? So for the diffuse type, the antibodies that is present here in this patient is the, first let's see the crest syndrome. This is known as a anti-centromere, and here it is anti-topisomerase. Topisomerase. So these are the two antibodies that is involved. If it is a crest, C for C for crest syndrome, and the C for centromere. So diffuse type, how the diffuse type will be presented? Most of the times, the diffuse patients will be having skin involvement. Okay, so there will be having salt and pepper rash will be seen. Okay, along with that, the patient face is severely damaged, so the fibrosis can look like the patient has a mask of faces, and lungs can be involved. So lungs can have pulmonary atrial hypertension. So this can be the cause of death for this patient. And the kidneys will be shut down. So the end stage renal disease will be involved. And for the heart, it can cause the fibrosis. Mitral stenosis can be seen in these patients. Okay, all these conditions which will be classically associated with the diffuse. Along with that, there is a calcinosis, that is also seen, and it is an irreversible condition that the patient will be suffering. That is what the scleroderma, and the treatment is immunosuppressants that you have to go for it. And next condition that you can see, this is the Sjogren's. Okay, this is the Sjogren's condition. So Sjogren's condition, also known as other name Milkless disease. Okay, Milkless disease. Sjogren, like a dry condition. Okay, this you can remember, this is completely dry condition. Okay, females more common than the males. HLA-DQ4 is involved in this patient's autoimmune condition, and the antibodies here, anti-SSA and anti-SSB. So these two antibodies are positive in this patient. And the features, if you can observe here, there is a fever, weight loss, night sweats, cerebral vasculitis, demyelinating lesions, bronchitis, bronchiectasis, lacrimal swelling, parotid swelling, lymphadenopathy, or the developing of the lymphoma, cryoglobulinemia, and the nephritis, articular like arthralgia, muscle pains and the weakness, peripheral neuropathy, and vasculitis. So whenever you see these patients, all these symptoms will be seen in these patients. So other than that, xerophthalmia, okay, dry eyes will be seen in these patients. So for this, we can go for the skimmer's test. So skimmer's test will be positive. Xerostomia. Okay, tongue will be dry. Okay, and xerotrachea. Xerotrachea. Okay, these are the symptoms that you are going to see. Orchitis or gonadal swellings. Patients can have parotid swellings because of salivation is not producing enough. That is also seen. The patient is producing the lymphoma, Hodgkin lymphoma, sometimes are the maltoma that is increased. And on the biopsy, you see lymphocytic rich. Lymphocytic rich is seen in these patients. The treatment is steroids. Treatment is steroids or the immunosuppressants that has to be given for these patients. Okay, so these are the important symptoms that you have, important diseases that you have to remember. Next, vasculitis. So vasculitis is developed as a large type, medium, and small, right? So large type is a giant cell arthritis. Giant cell arthritis, this will be involving of the temporal artery. Temporal artery. Steroids has to be given for this patient. Blindness is the cause. Next, Takayasu arthritis. This will involve the subclavian artery, which can cause the pulselessness in the patients. And the medium side arthritis. This is going to be the pan, which will be involving the kidney. But remember, this will spare the lungs. This will spare the lungs. Kawasaki disease. This is going to involve the coronary artery, and also Buerger's disease. Buerger's disease. This is going to involve the arterioles, veins, lymphatics. Okay, with the history of the smoking. We discovered this already in the surgery. Next, coming to the small vessel arthritis. Small vessel arthritis, we have monopolyarthritis nodosa or Wegener's and cryo or the cryoglobulinuria. So these are the symptoms that we are going to see. In the Wegener's, the point that you have to remember is which is positive here. So C ANCA is positive. So here it is a P ANCA positive. Okay. Infection will be upper respiratory tract infection followed by the granulomas. MPAN, this will be involving of the lungs plus kidneys. Difference between the PAN and the MPAN. So some points that you have to remember for these conditions. Hepatitis B, which will be associated with the MPAN. Hepatitis C is associated with the MPAN and the hepatitis B is with the PAN. So these are just glimpse of the what arteries and what is the involvement, okay, that you have to remember. Next, moving on to the respiratory condition. First and foremost important of the respiratory condition is the asthma. So whoever is suffering from the asthma, we all know that this is a chronic condition, and this chronic condition is going to cause the obstructive lung diseases. These obstructive lung diseases, why? Because it could be mostly mediated to the IgE mediated, or it could be due to non-IgE also. Okay, it can be due to non-IgE also, and this is going to cause the hyper responsiveness. But can I ask, is this reversible or the irreversible? Yes, this is a reversible condition. Okay, this is a reversible condition. Next, most commonly seen with the children. The most commonly seen with the children, but these children will be having the history of the IgE or the family history atopy that will be seen in these patients. In the adults, if you see, it could be type 2, or it could be type 2, which is known as a non-type 2. Okay, so type 2 is mostly allergic type, IgE mediated mast cells, and here it is a neutrophils which will be involving. So there must be inflammation, and severity wise it is also high, right? Severity wise also inflammation is more dangerous than the IgE because the drugs is very rare to find. And the patients here is the IL-5. IL-5 is for the eosinophils, and IL-13 is for the mucin, and IL-4 is for the mast cells. Here the involvement is the T helper cell 17 that is involved. Okay, T helper cell, and IL-1, IL-6, IL-17 all are going to involve the neutrophils involved in the type 2 type. How you are going to treat these patients? So first of all, whenever you see these patients, you have to treat accordingly with the test. So the best diagnosis for this patient is done by the best investigation, that is the spirometry. Okay, spirometry. On the spirometry, vital capacity is increased. Residual volume is increased. Okay, residual volume is increased, and the patient is having the expiratory capacity that is decreased. So this is what the patient is having in the spirometry. And then you are going to do the pulmonary function test. So on the pulmonary function test, you are going to look at this particular FEV1 by FEVC. So if it is less than 0.7 by 70%, then this is the classical condition of the obstructive pulmonary condition. So then you are going to give the test. So this is known as a methacholine test, or we can give the SABA. Okay, then again after the SABA, do the test. If it is increased more than 0.7 by 70%, this is the asthma. Okay, and if it is still less than 0.7 by 70%, then this is COPD. So this is how we are going to differentiate between this condition. Along with other, the DLCO is normal here. Okay, FEV1 is decreased as we discussed, and the peak expiratory rate, that is also decreased here. So these three will be decreased in the patients of the condition. That is also important point that you have to take note. Next, how you are going to treat these patients? So based on the GINA guidelines. So what guidelines we follow for the treatment? GINA guidelines. It is a worldwide guidelines that they follow. GINA guidelines. So it is like a step ladder pattern. So one step at a time, one step at a time. So based on the patient's symptoms. So for example, let's say I got the patient who is having more than 4 attacks per week, or the patient is having more than one attack in one night of whole week. So anything is danger. So these significant distress, patient is prompted to the hospital. So what we can do, we can go for the testing. Okay, FEV1. So after the FEV1, if you see there is an improvement with the LABA or the SABA, so we can start once the diagnosis is made. If the improvement reversibility is seen, we can start the patient on the low dose. Okay, low dose long acting beta agonist. Along with that, there is a significant inhaled corticosteroids can decrease the ongoing inflammation. So we can add the ICS. But unfortunately, this patient is having the severity. Okay, this patient is having the severity, and instead of it is less than 30%, okay, sorry, it is improved, right? So if it is improved, it is more than 30%. It is still less than 30%. So what we can go for this patient is the improvement is not seen. We can add the medium dose LABA plus ICS. So this is how we are going to start the patient and treat the patient as per the GINA guidelines. If ever the patient is having the acute attack, then we can go for the SABA plus oxygen. If the patient is having the severe attack, which is called as a status asthmaticus, so for this patient we can go for the IV steroids. Okay, SABA can be given for this patient. MgSO4 is given, and also oxygen is given. So this is how we are going to treat the patient with the asthma. And the monoclonal antibodies are present. So monoclonal antibodies, for example, you have duplizumab. This duplizumab is important for the IL-4. Okay, A, B, C, D. D is for 4. Omalizumab. Omalizumab is for the IgE. This is for the IgE. And benzralizumab. Benzralizumab. This is for the IL-5. This is for the IL-5. And mepalizumab. This is also for the IL-5. This is also for the IL-5. And tezepelumab. Tezepelumab. This is for the TSLP of the T helper cell. These are the monoclonal antibodies we use for the patients. Next, moving on to the chronic obstructive pulmonary disease. So patient who is suffering from the chronic obstructive pulmonary disease, we know that it is having the two conditions. One is emphysema, other one is the bronchitis, right? Inflammation. Let's see the emphysema first. So the emphysema has different types, guys. Central emphysema, or it could be pan-acinar type, or it could be preseptal type, or irregular, complete irregular type. So we have this kind of the acinar types. What is mean by the acini? Acini means alveoli, alveolar duct, and also the pulmonary or the bronchial duct that we consider as a acini. So central acinar means, so this is the alveoli duct. So there is a dilatation followed by the normal alveoli. Okay. So central, this is the distal, this is the proximal, and central is dilatation. So that is what's in here. So this is most common overall, associated with the upper lobe of the lung, and smokers. Pan-acinar. Okay, pan-acinar, everything is swelled here. This is the second most common, involves the lower lobe of the lung, alpha antitrypsin patients. Alpha antitrypsin patients. Preseptal. Preseptal means more distal side. Okay, more distal side. This is how the patients will be having. Sorry, this is not more distal, this is more proximal actually. So this is prone to, if it is more proximal, what happens? If it is, sorry, this is more distal, what happens? This is also involves the upper lobe, but this is going to associate with the spontaneous pneumothorax, right? If it is more distal, obviously it can cause the pneumothorax simply without the damage. So this is going to cause the pneumothorax in the patients, right? And irregular pattern, you are going to see the irregular pattern on the histology. So this is the histology variant, not commonly seen. This is the histology variant. Okay. Alpha antitrypsin is the autosomal recessive condition, involves the lungs. Along with that, it is involves the liver, both liver and the lungs involvement. That is the alpha antitrypsin condition. Okay, this is what the emphysema patients. Coming back to the bronchitis, what happens in the patients with the bronchitis? So the bronchitis is a condition. The patient is having the chronic productive cough, productive cough, and no other conditions like TB is negative for this patient, despite the patient is having the smoking history. That cough is more than 3 months continuously in the last 2 years. So then I have diagnosed this patient as a chronic bronchitis. Okay. So emphysema patients is going to develop the heart failure. And how this heart failure will be? This heart failure will be known as a pink puffers. Pink puffers. And the bronchitis patients can also develop the heart failure. This is known as a blue bloaters. Okay, blue bloaters, that is going to be seen in this patient. If both condition, emphysema and the chronic bronchitis is involved, obviously this is going to develop as a irreversible chronic obstructive pulmonary disease the patients will be suffering. Most common cause is smoking. Overall or the only cause smoking can be seen in this patient. But in India, biomass fuel who is in the rural regions, especially the females, is prone to due to biomass fuel that will be seen in these patients. Okay, that is what. And we have the gold criteria. So gold is going to tell us the criteria where the patient is presented. So the gold one will tell about the mild type less than 0.7 and more than 80% of the FeV1. And gold 2 is a moderate. The FeV1 is 50 to 80. And the gold 3 is 30 to 50. Profound, very severe. This is less than 30 that we are going to see. So gold criteria can be also asked in the examination. Okay, that should not be ignored. So how you are going to treat this patient? It is already an irreversible damage that is happened for this patient. Let's see the patient. More than one episode of hospitalization in the 1 year or if the patient is having the more than two episodes in the year, more than two episodes year respiratory distress that lead to the hospital visit, not the admission. Okay, this is for the admission, guys. This is for the admission for the breathing problems. This is only the hospital checkup. If you find any these two, if it is yes or if it is no. If it is yes, this is has to be severe condition. Okay, this has to be severe condition. We can start the patient on LAMA plus LABA. Dual combination, both has to be started for this patient. Okay, LAMA plus LABA. If it is no, then you have to check for the grading. Is it the grade 1 or the patient is grade 2? Grade 1 is the mild condition. So one therapy is enough. LAMA, low doses of the LAMA is given. This is the moderate therapy. And here you have to start with the LAMA plus or minus LABA. But the dosage is medium dosage. Medium dosage. But best treatment for this patient is oxygen, at least more than 18 hours. Okay, more than 80 hours. Not even a really the pulmonary patient is also going to get this much, but this patient needed the more than 18 hours has to be given for this patient, and this is going to be the best treatment. Okay, not the treatment of the choice, but this is the best treatment. And the patient, if ever die, cause of death is coronary artery disease, followed by heart failure. Okay, followed by heart failure. So this is about the COPD and the treatment. All right, next. Moving on to the another pulmonary diseases. So these are the restrictive lung diseases. Restrictive lung diseases that we are going to look after now. In the restrictive lung diseases, the most common is the idiopathic pulmonary fibrosis. So this patient is having. So what does mean by the idiopathic pulmonary diseases? So there is no cause at all, but most commonly seen with the males followed by the females. Obviously, there is a smoker's history or the patient is suffering from the genetic conditions from the family. That is also going to play the major role. Increased age, which is more than 50 years of the age the patient might be having. Okay, so it will involve the lung parenchyma. So the pathology involves the lung parenchyma. So whereas the asthma involves the bronchioles, but here it is involving the lung parenchyma. So on the physical examination, you are going to heard the crackles. So in the obstruction, it is wheezing. Here it is crackles. The good name is the Velco crackles. Velco crackle. Investigation of the choice is the high resolution CT scan has to be done for these patients. So on the high resolution the scan that you are going to look. So the findings of here is the honeycomb appearances, honeycomb pattern which will be seen of the damaged and also bronchiectasis which will be seen in these patients. Okay, so treatment. So antifibrotics is given for this patient. Antifibrotics. So the antifibrotics is the ninatinib. Okay, ninatinib is given for this patient. But the best treatment is transplant. Transplant has to be started. Okay, that is the treatment of the choice for this patient. Next, we also have the non-idiopathic condition. Non-idiopathic condition. So this is also another type of the restrictive pattern, but this is seen in the young individuals, non-smokers. Okay, females more common than the males that you are going to see in this patients. So this is just a difference, and this is highly good for response with the steroids. This is highly response for the steroids, and remaining all the features will be mostly same. And in the investigation of the choice is again HRCT. Here you are going to see the ground glass opacities. Ground glass opacities is seen in this patient, right? This is the non-idiopathic. Next, moving on to the ARDS. So ARDS, acute respiratory distress syndrome. So this is the acute respiratory distress syndrome, and most common cause these patients will have the death in the ICU is due to ARDS. Okay, ARDS is associated with most commonly pneumonia patients. Okay, pneumonia conditions. So there is a criteria that you have to follow. The criteria name is the Berlin's criteria. Okay, Berlin's criteria. There are the 4 points that you have to remember. The time of the onset is less than 7 days. Pulmonary edema is present, but it is not from the cardiogenic action, cardiogenic pathology. This is a non-cardiogenic edema. Radiological feature is showing the bilateral infiltrates, and the hypoxia of the patient is divided into the mild, moderate, and the severe. Okay, mild is 200 to 300, 100 to 200 of the peak expiratory flow, and the severity is less than 100. Okay, that is how we are going to find out. So this is the Berlin's criteria. Okay, at least two has to be presented for the patients. You further has to be treated. Okay, so these pneumonia can go into the respiratory failure for the patients. Okay, type 1 respiratory failure that can be seen. So what we have to treat for this patient is the we have to go for the patient with a mechanical ventilation. Okay, there has to be treated with a mechanical ventilation. In the mechanical ventilation, the settings of the tidal volume is less than 6 ml per kg. Peak expiratory flow rate has to be, this peak expiratory flow rate has to be increased, and FiO2 fraction of the FiO2 you have to maintain less than 60%. So this is the best pattern that we can save this patient from the ARDS. Okay, that is a 1 point. Next, another condition that you can see here. So this is the bronchiectasis. Okay, bronchiectasis. Bronchiectasis is two types. One is the genetic, and other one is the acquired due to infections, recurrent infections. In the genetics, you have to take note about the Carter-Jenner syndrome. Okay, Carter-Jenner syndrome, which is also known as ciliary dyskinesia. This is also known as a ciliary dyskinesia. So these patients will be having the symptoms of sinusitis. Sinusitis will be seen in this patient, and dextrocardia, that means opposite, not on the left, it is on the right side of the heart. The right heart will be seen, dextrocardia, and bronchiectasis. Bronchiectasis. So this is the feature that the patient will be having. So the defect here is the cilia, and the cilia is lacking of the dynein. A cilia is lacking of the dynein. So if the cilia is problem, infertility is also seen in this patient. Infertility is also seen in this patient. And on the absorption, if you see, the patient will be having tam track appearances. This is known as a tram track appearances and signet ring appearances. So this is the signet ring appearances. So this is what seen in this patient. But cardiogenic is very rare. Okay, we don't see the right side of the heart commonly, right? So this is the most common post-infection. COVID-19 patients have, most of them had this bronchiectasis developed. Okay, and before the COVID-19, there are many other pneumonia causes that is also showing this same condition that is presented, right? So this is the ARDS that we have discussed. Next, moving on to the next condition. So that we are going to discuss here is the pneumonia. Curb 65 scoring. What is this curb 65 scoring? Before you have to take note about the curb 65 scoring, let's see what are the causes. Community acquired pneumonia. This is most commonly due to strep pneumoniae. Okay, hospital acquired pneumonia. This is due to staph aureus. Ventilator acquired pneumonia. Again, this is also staph aureus or actinobacter. Actinobacter. And patients who is developed in the immunocompromised, or we can say HIV patients, This is pneumocystis. And atypical pneumonia. This is mycoplasma. This is mycoplasma. Okay, this is the pneumonia and their causes that you have to remember. And the curve 65. Why the curve 65 scoring is very important, guys? Because if you don't treat early, the sepsis is the most common cause associated with the pneumonia. So that's why this criteria is important, right? So if the patient is having the confusion, urea is more than 7, respiratory rate more than 30, systolic less than 90 or the less than 60, age is more than 65. Every point is given 1 point. If it is 0 to 1, outside care. 2, it is an inside care. Inpatient has to be in the general ward. More than 3, ICU admission has to be treated for this patient. So this is the criteria that we follow for these patients. Okay. Next. Here we will be discussing of the respiratory failures. Okay. We have the type 1 and we have the type 2. Okay, so type 1 is decreased oxygen, type 2 is increased carbon dioxide. So here it is a cause of hypoxia. Okay, mostly pneumonia. This is hypercarbia, COPD patients. Okay, and all the type 1 patients in the severe stages, they develop to the type 2. So type 2 is comparatively it is a severe because it is a combination decreased oxygen and increased carbon dioxide. So that is going to be the difficult for the patient. So hypoxia is deficient. I can give the O2 therapy for this patient. But for this patient, I have to go for the BiPAP. Okay, BiPAP has to be done for this patient. Next, we also have the type 3. It is atelectasis, especially seen post-op patients. Next, we also have the type 4. These are the miscellaneous, okay, rarely asked. This is due to sepsis. So sepsis is due that tissue perfusion is decreased, right? So this sepsis tissue perfusion is decreased. It is going to cause the lungs damage. So that's why type 4 is type of a heart failure that we are going to see here. Okay, next condition. Next condition that we are going to discuss, lights criteria. Here you can see this is the lights criteria, and where you use the lights criteria, you use for the pleural effusion. This is used for the pleural effusion. Okay, most common cause here again infection only, pneumonia, but it is subdivided as a exudative and transudative. Exudative is pneumonia or the patient who is suffering from the cancer, and the translative is congestive heart failure, liver disease, renal failure. Secondary causes is the translative. How can we differentiate? Using the lights criteria. If you see the pleural fluid protein and the serum protein more than 0.5, or the pleural fluid LDH and the serum LDH is more than 0.6, pleural LDH is more than 2/3 of the serum LDH. If any one is following is positive, then we can consider this patient as a lights criteria and the pleural effusion is done. And what we are going to treat this patient, you can do the thoracocentesis for this patient to treat. That is a one point that you have to remember. Next condition, that is a sarcoidosis. This is the last condition that we are going to discuss in the pulmonary chapter. Okay, so I think video is lengthy, but please stay with me and read these topics. This is going to help you a lot, guys. Next, we have the condition of the sarcoidosis. Okay, sarcoidosis is a classical non-immune granuloma. This is the non-immune granuloma. Okay, non-caseating granuloma. So there is a two difference, non-caseating and non-immune granuloma. So this is a condition of the granuloma with autoimmunity and the multiple granulomas development. So multiple granulomas are developed with the sarcoidosis. Classical presentation of the patient is fever, weight loss, lymphadenopathy. Okay, lymphadenopathy. So all these features, if you observe, this is present in the TB and also sarcoidosis. Okay, so this is the feature that we are going to see. On the biopsy, we will be having the non-caseating granuloma, whereas TB, which will be consisting of the caseating granuloma, right? That is the differences. Next, coming to the, there is a condition that is known as a Lofgren's syndrome. So Lofgren syndromes, the patient will be having the arthritis, patient will be having the lymphadenopathy in the lungs, and along with that the patient will be having this condition. What is this condition, guys? This is the erythema nodosum. Erythema nodosum. F3 is present, so this is a condition of the Lofgren syndrome with the sarcoidosis. Okay, this is a variant of the sarcoidosis. And sarcoidosis is not just involving the one, his sarcoidosis will be involving the multiple, but the most common is the lung. Okay, most common is the lung. It will do the severe destruction to the lungs. So that is done with the help of the scadding staging. So the staging name is the scadding. Stage 1, bilateral hilar lymphadenopathy, but the parenchyma is normal. Stage 2, hilar lymphadenopathy with a pulmonary infiltration. Here you can see. Stage 3, pulmonary infiltration, but hilar lymphadenopathy is decreased, but the patient is having the fibrosis. Stage 4 is completely, it is fibrotic. So that is what it is going to associate. Next, sarcoidosis can involve the multiple syndromes in the body. For example, let's take it is involved the heart. It is going to cause the tachyarrhythmias. Okay, tachyarrhythmias, and we discussed it can cause the dilated cardiomyopathy, or also it can cause the dilated cardiomyopathy or the restrictive cardiomyopathy. Okay, so this can cause sudden death in the patients. If the patient can involve the nerves, so this can cause the seventh nerve palsy. Seventh nerve palsy is involved. Okay, next, if it is involved the kidney, it can cause the end stage renal disease. Okay, end stage renal disease will be seen if it is involving here. Okay, that is also one point that you have to remember. And it will involve the parotid, so there is a swelling of the parotids which will be seen. Okay, next, in the kidney only, it can cause the nephrogenic DI, diabetes insipidus is one of the cause. Okay, skin, on the skin, erythema nodosum is seen, and also lupus pernio. Lupus pernio is also seen. That is what. Coming to the diagnostics, calcium is raised, AS levels is raised, CD4 plus CD8 levels is raised. Okay, so these are the levels that you are going to see in this patients, and the treatment is always steroids. And if it is not responding, go for the immunosuppressants. What is the cause of death? Is going to be primary respiratory failure due to fibrosis. So this is the overall just glimpse of the sarcoidosis questions that is asked in the previous examination. Okay, that is what. Next, we see the two different types of the radiographs here. Okay, so first radiograph that you are looking at here is the this one. So what is this one? The opacity of the small mass. This is known as a Ghon's focus. This is known as a Ghon focus. And here there is a bunch of increased lymphadenopathy. Okay, hilar lymphadenopathy is positive for these patients. So this condition is nothing but tuberculosis, right? This is the most common tuberculosis in India. Every patient might be having this condition, right? Next, if the patient is developed primary, it will include the lungs, and the cause here is the aerosol. Okay, and what is the patient's secondary development? It could be lymph nodes, or it could be other organs. But here the root is hematogenous. From the lungs we have got this condition. Okay, this is what. And the Ghon's focus and the lymphadenopathy, which will be known as a Ghon's complex. This is known as a Ghon's complex. When you do the histopathology or the biopsy, you are going to see caseating necrosis. Caseating necrosis will be seen in this patient. And this is the secondary TB, which we call this as a miliary TB. So this scattered complete destruct is due to miliary TB. This is the activation, reactivation of the syndrome of the latent TB. Okay, this is what TB. Okay, this is how we are going to treat this patients. That's just I wanted to differentiate from the here this one. So here you can't see the Ghon focus, only lymphadenopathy, but here you are going to see the Ghon focus and miliary TB is also seen. Okay, That is what the major differences. Next, moving on to the human kidney disease. In the human kidney disease, we have the important points that you have to take note here is the condition the human kidney is involved. What is the most importantly involved? That is a glomerulous diseases. Okay, glomerulus. But what is the glomerulus functional unit? How the GFR is maintained in our body? But one is the filtration unit. One is filtration unit. What are those filtration unit consist of? Basement membrane is one. Okay. Podocyte, which is also known as a food processes, podocytes and the food processes, and endothelium. Endothelium. All these are plays the major role for the filtration unit. How can we know this filtration unit is decreased? You have to do urinary albumin creatinine ratio. Okay, if it is more than 30 or it is more than 300. So if it is more than 30, this is the microalbuminuria. So that means the structures is not saving albumin is going from the body. If it is more than 30 macroalbuminuria, so already the kidneys is at the edge of the destruction. So that is what the another condition that you have to remember. Next, renal artery stenosis. So here you can see normal artery versus the atherosclerosis. Normal artery versus the atherosclerosis. So renal artery stenosis patients most common cause is the atheroma. Second most common is a genetic condition. This question is asked fibromuscular dysplasia. Fibromuscular dysplasia is the condition. So these patients symptoms is hypertension, uncontrolled hypertension. Despite of the having the any drugs, this condition is uncontrolled. What we call this discontinuously the BP is raised. This is the resistant hypertension that the patient is having, and the patient is having the flank pain because it is a compression, the blood is not perfusing properly. So these are the symptoms. So when you see these patients, you are going to consider the patient to take some test. So first one is the serum creatinine, and the serum creatinine is raised in these patients. Then you go for the ultrasound. Okay, when we go for the ultrasound, we are going to see the Doppler. So where the Doppler, which we will consider this, the proximal is more blocked than the distal. Okay, proximal part is more involved and blocked. That is what we are going to see. And if it is a severe, it look like a beaded appearances. So beaded appearances means like this. This is the vessel. So you are looking like a beaded appearances. That is what it is going to see. Next, the best investigation of the choice. The best investigation of the choice is the angiography. Angiography has to be done for this patient. So the stenosis is properly visible for this patient. Treatment is patient has to be given the spironolactone because it is a resistant condition, and we can go for the stunting. Best treatment of the choice is stunting. And the contraindication for this is ACE inhibitors. Okay, ACE inhibitors. Sorry. So contraindication, if it is a bilateral renal artery stenosis, then ACE inhibitors are should not be given for this patient. Okay, that has to be not given for this patient. But if you want to treat these patients, you have to treat with one of the diuretics, one ACE inhibitors. If it is a unilateral only, then CCBs. Three drugs has to be started for before the stunting is done for these patients. Okay, that is the treatment of the choice for this patient. Next, renal tubular acidosis. Renal tubular acidosis is four types. Okay, but we are going to discuss mostly three types only: type 1, type 2, type 4. Type 3 is not commonly seen, and very rarely patients are suffering from this. Okay, that is not considered. So RTA1, RTA2, and the RTA4. Okay, we have three conditions. So among them, which is the most common? So the most common will be the RTA4. Okay, RTA4 is the most common type. Next, they involves the distal convoluted tubule, proximal convoluted tubule, and this involves the only the collecting tubules that is involved here. Different features. Causes coming from multiple myeloma, Here also it is a multiple myeloma, and here it is diabetes mellitus type 2. Diabetes mellitus type 2. So the defect in the distal convoluted tubule, that the sodium and the calcium channels are not working. Okay, they are not working. So H plus secretion is also dysfunction because of DCT involvement. So what happens for this patient? Urinary pH is increased. Urinary pH is increased in these patients. Due to decreased sodium and chloride is absorption is not problem. So aldosterone is going to activate. So the sodium is going to increase in the body. Potassium is going to excrete in the body due to activation of the aldosterone. So you are going to see hypokalemia also. Hypokalemia also in this patient. So that is a RTA1. Okay. Next, coming to the RTA2. Again, multiple myeloma. PCT is not problem. PCT is the problem here. So majority of the reabsorption is decreased. Majority of the reabsorption is decreased, and HCO3 is also decreased here in this patient. Again, this will cause the aldosterone to activate, sodium increase, potassium decrease, sodium will increase, potassium will decrease. That is the one which we are going to see. So the hypokalemia is seen here also. Okay, hypokalemia is also seen in this picture also we are going to see. And the urinary is going to be acidic, because H plus ions are going out. So that is going to cause the urinary acidosis. Okay. Next, third type. So in the third type, the patients who is suffering from the third type, the defect itself in the collecting tubule. Aldosterone is present here. Collecting tubule is defective. So aldosterone is not working. So the sodium will decrease. So sodium will decrease. Potassium will increase. So the only condition where you see hyperkalemia, that is the RTA4. That is the RTA4, and the urinary pH is acidic. Okay, so this is the different points that you have to take note. RTA features, and you can answer. Okay, only the drug that is associated with this condition is the amphotericin B. That is the RTA type 1. Next, moving on to the another important points that you have to remember is the syndromes. Okay, first, if it is involved the PCT, so this is the proximal convoluted tubule, so PCT is involved, so there is a dysfunction, so this can develop the Fanconi syndrome. Okay, this is going to develop the Fanconi syndrome. Okay, type 1, this is going to be the type 2 arteria. Okay, this is going to be the type 2 arteria. All right, next, the loop of Henle. So in the loop of Henle, if it is involved in the thick ascending loop of Henle, this is going to develop as a Bartter syndrome. Patient can develop the Bartter syndrome. So sodium, potassium, chloride is dysfunction, is not going to form in these patients. Next, Gentleman syndrome. It is going to in the distal. This is the Gentleman syndrome. Gentleman syndrome, sodium and chloride is dysfunction. Next, collecting tubule. Here we have the Liddle syndrome. Here it is actually ENaC channels are more. So more aldosterone is coming from the ENaC channels. Okay. So these are decreased, whereas Liddle syndrome is increased due to ENaC channels. All right. Next, coming to the important points that you have to take note. Another image based question can be asked. What are the drugs? So the PCT drugs are the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors. Example, acetozolamide. Okay, so detailed discussion, watch the pharma. Okay, just the image based here you have to understand. Next, loop of Henle, osmotics, mannitol, right? Distal convoluted tubule is thiazides, thalidomide. Next, thick ascending loop of Henle, these are the loops, furosemide. Okay, image based question can be asked. Collecting tubule, potassium sparing agents, spironolactone. So these are the image-based questions can be asked in the examination, right? Next, moving on to the kidney diseases. These are the severe kidney diseases that can be seen. First, we will be starting with the chronic kidney disease. Okay, chronic kidney disease. So the patients whoever is suffering from the chronic kidney disease, the most common in India, diabetes mellitus is the most common, which will develop as a nephropathy. This will develop in the patients as a nephropathy. So how you are going to screen this patient? If it is a type 1 diabetes mellitus, please check within the 5 years they can develop the nephropathy, or the patient who is from the type 2 diabetes mellitus, they take at least a 10 years. So within the 10 years you have to take the precautionary measures for these patients. That has to be done for these patients. Next, what is a CKD? Okay, what is a CKD? So it is a going to decrease the GFR. In the stage 1, still the patient is having the more than 90 ml perfusion. Stage 2, it is decreased to the 60 to 89. Stage 3 is 30 to 59. Stage 4 is 15 to 19. Stage 5 is less than 15. It's already end stage renal disease this patient is having. So CKD is nothing but the patient is not having proper reabsorption. Okay, patient is not having the secretion that has to be thrown out is not happening here, and patient electrolyte imbalance is significantly increasing. Electrolyte imbalance is significantly increasing. So this is the majority of the patients will be suffering from. And how you are going to treat these patients? So the treatment for this patient is the supportive, depends on the patient position and patient diabetes mellitus underlying cause we have to treat, and patient electrolyte imbalance has to be treated, other conditions has to be treated. If the patient is having the end stage renal disease, what we are going to do? We are going to do the patient's dialysis. That is the first thing that we are going to do. And the most common side effect for the dialysis is the hypotension. It is going to be hypotension for this patient. Okay, so best procedure to do the a patient is IV shunt, or we call this as a AV graft. AV graft we are going to use for this patient, right? What does the dialysis will do? Ultrafiltration of the plasma. Ultrafiltration of the plasma. That the end stage renal disease is going to done for this patient, especially for these patients. So let's say stage 1 and 2 supportive treatment will work, but patients with the third to these stages, the patient definitely need the dialysis. Okay, irreversible damage is seen this condition. So this is what the patients, and another supportive treatments like EPO stimulants you can give for this patient, and phosphate binders like Selvamir. Okay, these are the phosphate binders. Okay, and also potassium binders like Patiromir. These drugs has to be given to detach from the and detoxify from the kidney. So just general overview. And the acute kidney injury. So acute kidney injury has the three types: pre-renal, intrinsic renal, and the post-renal. So until here, I will tell this is the pre-renal, this is the post-renal, this is the post-renal, this is the intrinsic. So this is the pre, this is the post, and this is the intrinsic. So causes. Pre-renal is blood loss, dehydration, heart failure, sepsis. Sepsis is the most common type. Okay, sepsis is the most common type. Intrinsic, due to drugs, toxins, prolonged hypotension, another drugs, toxins, autoimmune disease, and the infection. This is the intrinsic factors. Post-renal, obstruction due to cervical cancer, BPH, stenosis, and prostate cancer, calculi. All this will be post types. Next, how you are going to check? With the help of the rifle criteria or the Akin criteria. Akin criteria is more commonly asked in the examination. Let's see the stages. Stage 1, increased creatinine more than 1.5 and the urine output is less than 0.5 in the last 6 hours. Stage 2, creatinine is 2 times and the urine output is still 0.5. Stage 3, creatinine is more than 3 and the urine output is decreased to 0.3. And what is the treatment? Treatment is underlying cause you have to treat for this patient. It is still an acute condition only. Next, moving on to the glomerulonephritis. In the patients who is suffer from the glomerulonephritis, it is going to cause the nephrotic syndrome or it can cause the nephritic syndrome. So let's see the differentiation between the nephrotic and also nephritic. So who is suffered from the nephrotic syndrome, this is going to have the proteinuria. So more and protein is lost in this patients. So the proteinuria is more prominent. And edema is seen, like anasarca is seen in this patients. And lipid is going to lose, lipiduria is seen in this patient. And albumin is decreased. Okay, albumin is also decreased. Hypoalbuminemia is seen in this patients. Nephritic syndromes, this is going to RBC cast, that is called the hematuria is seen in this patient. Hypertension is seen. Edema is seen. Yes, edema is still seen in this patients also. And also hypo C3 protein, hypocomplementemia is seen in this patients. What are the causes? The most common is minimal change disease. Minimal change disease. This is most common in the children. Okay. FSGS, focal segmental glomerulosclerosis. FSGN, focal segmental glomerulonephritis. This is seen in the patients of the adults. Membranous glomerulonephritis is seen in the old individuals. Coming to here, most common is IgA nephropathy, or we call this as a Buerger's disease. It's not a Buerger's disease, it's a Buerger's disease. Okay, this is seen in the adults. And next, post-streptococcal glomerulonephritis. This is again a child. Okay, and RPGN. This is going to cause the end-stage renal disease for the patients. Okay, so these are the symptoms that we have in this patients. Right. Next, only the few points, specific points that you have to take note here. Minimal change disease. Okay, the condition is minimal change disease. So minimal change disease is most commonly in the children, and it have the good prognosis. Why it has a good prognosis? Because it is going to respond for the steroids. On the electron microscopy, you are going to see the loss of podocytes. Okay, so here you can see. So this is the basement membrane as I discussed. So this is the food processes, or we call this as a podocytes. And here you can see this is the endothelia. So these patients, the podocytes are lost. So the podocytes is lost, that is seen in the patients of the minimal change disease. So the treatment is steroids. Okay, at least for the 6 weeks we have to give the steroids for these patients. Okay, next, another type. This is the membranous glomerulonephritis seen with the old individuals. HIV and the hepatitis B or the C is common. Okay, this is more common with the membranous glomerulonephritis. Other than that, the facts is not so important. Membranous proliferative glomerulonephritis. So for these patients is seen with the adults. Okay, again hepatitis B or the C, which will be seen in these patients, and you're going to see the tram track appearances. Okay, tram track appearances is seen in these patients. Okay, so here you can see. So how the patient will be presented. So tram track appearances which will be seen in the patients of the membranous proliferative glomerulonephritis. Okay, next one, focal segmental glomerulonephritis. So this is most common in adult patients. Okay, most common in the adult patients. Cause is idiopathic. Okay, cause is idiopathic only. And infection, if it is associated, it is HIV infection in the adults. And they have separate classification. Colombian classification. Colombian classification is present for them. And the treatment is steroids. So you are going to see here there is a presence of the sclerosis. Okay, so this is all the glomerulus is going to go for the sclerosis. Focal segmental glomerulosclerosis or the scarring will be seen in this patients. Okay, next, diabetes nephropathy. Diabetes nephropathy. So in the diabetes nephropathy, this is due to CKD, hypertension. So the kidney changes and the diabetes mellitus, the patient will be having this condition. So in the earliest, there is a feature that this patient will be having basement membrane thickening. So basement membrane is thickening for this patient. And late stages, there is a nodules. Okay, nodular sclerosis. These nodules are known as a Kimmel-Sten Wilson lesions. Kimmel-Sten-Wilson lesions that is seen here. So you can see this is the nodules appearances that we are going to see. Okay, that is how we are going to see. Next, another two conditions. Okay, so first, this is the post streptococcal glomerulonephritis. As I checked, this is seen with the children, right? So whoever is having the post strep infection, this patient is going to develop. And when you check these patients on the electron microscopy, you are going to see these humps. Okay, you are going to see these humps. This is known as a subepithelial deposits or the subepithelial humps that you are going to see. And the immunofluorescence, it is look like a granular. Okay, it's look like a granular type. Okay, that is what you are going to see. And these patients is going to associated with the hyaluronic antibodies hyaluronic antibodies, and also ASO titers is also positive for this patient. C3 levels is decreased, it is going to differentiate from the IgA disease. Okay, so how the IgA disease is present here? So IgA is going to have the linear pattern. IgA is having the linear pattern, and the glomerulus is no humps is seen. No humps is seen in this patients, and IgA is seen with the adults. Okay, most common or overall, and severe hematuria is seen in this patient. Upper respiratory tract infection, which is less than 1 week. But here the patient has to be developed this post streptococcal. It will take more than 2 weeks to develop this infection, but this development of the infection is less than 1 week history only, and C3 levels is absolutely normal, and this infection is also viral. Okay, this is actually strep infection bacterial. So this is the difference between the IgA and this one. Okay, that is the one thing. Next, as I say, if there is a lung involvement plus liver involvement, so this is the anti alpha trypsin. Okay, alpha antitrypsin condition. If lungs is involved plus kidney is involved, so this is the good pasture disease. This is the good pasture disease. Good pasture disease in the kidneys, it is involves the type 4 collagen. Type 4 collagen is involved in this patients. So classical finding hemoptysis, hematuria. Then you have to understand, oh, this is the condition of the good pasture. Next, kidneys plus, okay, patient is having the involvement of the ear plus patient is having the eyes. So this condition is known as a Alport syndrome. Alport syndrome. This is the X-linked dominant condition, which again involves the alpha type 4 collagen. Alpha type 4 collagen involvement is seen. So the patient is having the sensory neural hearing loss and anterior lenticonus and nephropathy that is going to see here. So these are the some conditions that you have to remember. Let's continue with the discussion of the ECG, one of the most important topics. So first we will be, before we understand the ECG, we have to take note about the ventricular repolarization and the atrial repolarization, okay, or depolarization that we have to understand. So in the ventricular depolarization, the resting membrane potential will be at the EIT, okay, minus EIT. So from here, so we will be having sodium influx. So more positive ions, so it will reach the threshold that is 40 plus. This phase is known as a depolarization, and after reaching the depolarization it has to go for the repolarization. So we start to expel the positive ions such as potassium, and there is a plateau phase immediately. What happens in the plateau phase? We are actually throwing the potassium out, but simultaneously there is a calcium inside. So this will lead to the plateau phase of the action potential, and after that, once the calcium is entered and completed, so completely there will be only out of the potassium outside. So this will cause the repolarization of the phases, and each of them having the different phases. This is the fourth phase, this is the first zero phase, and here it is the first, and this is the second plateau, and third one is the repolarization, and again back to the 4 arresting membrane potential. So this is the ventricles. Next, coming to the atrium. In the atrium, we have not these many phases. At least we only have main phases like 4, 1, and 3. So why it is like that? So because if you observe, ventricle is more bulky and muscular, but whereas atrium is not that bulky. Atrium is only the very thin muscular organ. So that's why this has a very less action potential. And how it is going to be? So here also there is a influx on the sodium. Okay, there is an influx of the sodium, and there is an influx of calcium, which will be going to cause the depolarization, and after that there will be slow potassium outside and completely potassium outside. So this will cause the repolarization of the atrium. Mostly the most important is the calcium that will be causing the active depolarization of the atrium. So why it is important and what it is makes the difference between the depolarization? Because we have the electroconductive system. So from the SA node, here you can see from the SA node, so there is a elective conduction that is passing here to the AV node, okay, and followed by the bundle of His and the right bundle branch and the left bundle branches. So this thick muscular organ should get all the electrical conduction from the pacemaker to the bundle, all the myocytes we have to receive. So again come back to and revise SA node to AV node and AV node to bundle of His, and from here it is going to have the right bundle branch and the left bundle branch. So this is the system that we have. Next, how the ECG is going to form. So let's start. So always remember, heart will have the positive, and our heart is always traveling on the positive notes. Okay, heart is always traveling towards the positive vector, and here this side we have the negative. This is the negative vector opposite to the heart. So how these vectors will be working? For example, the electrical conduction from here to this way, when it is passing, so this will show the positive deflection. And if ever it is going to show the major depolarization, it will be raised. And if it is show the negative vector, so this will be formed downwards. So this is how the ECG vectors will be formed, right? So we will just glimpse how the each of the will be formed. So let's start with one by one. So first, when there is a nothing activity is going on, so we will be seeing of the isoelectrical line. Isoelectrical line means there is no activity is passing, and after that atria is contracting, your SA node here is acting, so this is going to form the P wave. Okay, and after uh, complete atrial contraction, the nodes that is passed towards the AV node, but AV node has a specific the entity that it will cause the delay in the electrical conduction. How many seconds it will cause the electrical conduction delay? Less than 0.1 seconds. So that is how you are going to see here there is a isoelectrical line, there is no activity, which is known as a PER segment. Next, after that there is a bundle of His. Once the bundle of His is reached, it is going to give the bundle of His to all the ventricles, so where you are going to get the QRS complex, and after that we are going to have the once the entire is going to contracted, it will be relaxed. All the valves is relaxed. This phase is known as a isovolumetric relaxation, and again we will be having there is no activity going on, and this activity is known as a isoelectrical activity, and ST segment. No electrical conduction is happened, and after that we will be having the repolarization. So repolarization means all the cells is moving backside, so the cells is going backward, then we will be having the T phase. This is how we are going to have. So come back again, see how the each and everything is formed. P wave. What is the P wave, guys? As we discussed, it is a atrial depolarization. QRS complex. QRS complex is the ventricular depolarization, and T wave is the ventricular repolarization. So this question can be directly asked. So PR segment, ST segment, these are isoelectrical lines. This is due to AV delay, and this is due to isovolumetric relaxation, and QT interval, PR interval, and the RR interval. So this is the very big intervals that is going to tell us how the activity is going on. So these are the different types of the cell waves and their intervals and the segments that you have to remember. How we are going to check this ECG waves? So we are going to use classical, that is the 12 lead ECG. We are going to use the 12 leads of the ECG, and in that we have unipolar leads, and other one is the bipolar leads. So bipolar leads are the lead 1, lead 2, and the lead 3. Unipolar leads are two types. One is augmented types. So these augmented types, you all know the names AVF. A, which is associated, that is the augmented type. AV, L, and AVR. Along with that, we also have the precordial leads. These are the chest leads, right? V12, V6, and sometimes V7 and V8 is also present. So these are the vertical leads, these are the horizontal leads. So we have unipolar and the bipolar, these 12 leads of the ECG that we are going to check. How we are going to check? Here you can see this is how the vertical leads will be checked. So right atrium, so this is the right atrium, and this is the left atrium, and inferior heart we are going to take a look. So this is the Einthoven triangle. This triangle name is known as a Einthoven's triangle, is the first discovery of the heart conduction. So what the Einthoven triangle will explain us is 1 plus 3 is equal to 2. Okay, so for example, here you can see the right atrium is passing the electrical conduction towards the left atrium, and the left atrium is passing the conduction to the inferior part of the heart. So when we combine this both, we are going to get the 1 plus 3 is equal to lead 2, because right side of the heart is not much is active as the left side of the heart. So we have considered this Einthoven's triangle. Next, moving on to the another triangle that you can see, this is given by the Goldberger. Okay, this is known as a Goldberger's triangle. He given the AVR, AVL, and the AVF. He didn't change the much. He just changed the views of the heart. So with the using of the augmented leads and the unipolar leads. Next, coming to the precordial leads. Precordial leads, here you can see how the precordial leads are placed. So this is the heart. This is your backside. Okay, this is the sternum, and we are placing this one. So left side, first only the wave, that is the first lead, but that we are going to put is the, this is the left side. Sorry, this is the right side we are going to keep, and remaining all we are going to keep on the left side of the heart only, right? And how they are looking, where they are looking, for example, this is looking at the lateral part of the heart, this is looking at the lateral part of the heart, and this entire V22, V3, V4, V5, this is looking anterior and also directly into the septal. Okay, anterior septal, and this one is going to look at the right side of the segment. Sometimes this is a not much is considered V1 in the chest leads. Next, another picture that you can see, what we have just changed is the triangle shape. Right here you can see these are the two triangle shapes we converted into as flexible to look after the how the heart function is working. Okay, so here you can see Einthoven triangle is converted. One wave is to the lateral and the two wave is to the inferior, same as the three, which is onto the inferior. AVF is for the inferior, that means port side, and the AVR is most of the left side, and AVL is also most of the left side and the lateral side that we have converted, right? So moving on to the general normal picture of the ECG, how it is going to look like. So let's see here. So this is the entire one box that we have looking at. In this entire one box, the waves, how they are going to fall, 25 mm per second, 25 mm per second. This is the speed of the paper. This is the speed of the paper, and one box is consisting of the 1 MV voltage. This is consisting of the 1 MV voltage, and the size is approximately 1 mm. Okay, approximately 1 mm it is going to consist. And if you look borderly, this small box, okay, this small box, how many seconds it is? It is 0.04 seconds. And when I combine the big box entirely, it is going to give us around the 0.20 seconds. So this is how the ECG paper is, we are going to get the traces. Then we have to decide what are the leads and what are the looks that we are going to get. The best lead in the whole ECG is the 2. It is going to tell us about the heart rate and the heart rhythm. So that is why lead 2 is given the separate strip, and along with the remaining all the views of the 12 leads ECG that we are going to look here. Next, one by one, important points about the each one. So first we are looking at the P wave. What is the P wave considers? It is a atrial depolarization. Most of the times atrial depolarization is smooth and the upright, right? We just thought this is going to be in the upright only. And why it is upright? Here you can see this is the right atrium and this is the left atrium, right? This is the right atrium, this is the left atrium, and we combine, this is the whole atrium that we are going to look. And how many seconds? Less than 0.12 seconds. If there is an absent P wave that is seen in the atrial fibrillation, sawtooth P wave like this, sawtooth P wave that is seen in the atrial flutter, peaked P wave, okay, this is like peaked P wave, this is seen in the right atrial enlargement of the P pulmonale, and notched type of the bifid, for example this like. So this is the P wave. If you look, this is the P mitrale, and inverted P wave is seen in the ectopic atrial rhythm. Next, coming to the PR interval. PR interval is very important, and the duration is also asked in the examination. It is between the 0.12 to 20 seconds. What is the PR interval? We just discussed PR interval, which includes the PR segment and also P wave, right? This involving the P, and also it is involving the PR segment. So segment and the waves, if it is combined, that is the interval. That is what PR interval. And the important points that you have to take note, if there is a more than prolonged PR interval seen in the blocks. If PR interval is shortened, that is seen in the WPV syndrome. Okay, these two examples has to be remembered. Next, how we are going to check the normal heart rate and the abnormal heart rate. So these are the waves that we already discussed, and the normal heart rate is going to be around the 60 to 100 or 120 beats per minute. Okay, if it is less than, it is going to be the slow. If it is more than, it is going to be the fast heart rate. How we are going to calculate? Based on the ECG, how we are going to calculate? So first of all, we are going to look at the heart rate based on the bars. Okay, for example, this is the entire big box. Okay, and in the big box we already have some of the small boxes. So if you consider the big boxes, 300 into big squares in the entire strip that you got. For example, I have given you this strip. Okay, I have given you this strip, and in that strip you have to calculate 300 divided by the big squares. We are going to get the heart rate. And if you can't do this also, you can go for the 1500, and you are going to calculate with the small squares. Okay, you are going to calculate with the small squares, but it takes a lot of time. You can use this 300 by big squares. We are going to get the heart rate. What if it is irregular? Okay, this is both are for the regular heartbeats. What if it is a irregular type? So in the irregular type, we basically use the QRS complexes. Okay, we use the QRS complexes. How it is? 30 large boxes. Okay, 30 large boxes of QRS complexes into 10 into 10. That is how we are going to calculate. So this is the basic principle that you are going to look for the most of the heart rates that we are going to look. Next, axis deviation. This question is can be also asked in the examination. First of all, you have to take note about the normal axis deviation. So normal axis deviation is minus 30 degrees to 110 degrees is considered as a normal axis deviation. And above this is the limit that we are going to have the left, right, and the extreme axis deviation. So there is a thumb rule that you can remember. Okay, there is a thumb rule that you can remember. So your lead one is the left and the lead AVF is the right. Okay, and if both waves are upright, okay, if both waves are upright, then it is a normal axis deviation. Okay, but your left hand is only upright, but your AVF is in the downright, that means negative. So this is the possible left axis deviation, and your lead one is in the down, but the right one is on the upright. So this is the right axis deviation. That means, see here you can see left hand is upright, so left axis deviation. Right hand is upright, so this is the right hand deviation. Next, the negative one, here you are seeing this is the negative one both. This, if both are negative, for example, the both are negative, then it is considered as a extreme axis deviation. So this is how we are going to calculate the axis deviation. Next, we will be discussing of the different bradyarrhythmias and the tachyarrhythmias. Okay, one by one. So first one, here you can see sinus bradycardia. How much is a sinus bradycardia? As I said, it is a less than 60 beats per minute. This is considered as a sinus bradycardia. Most of the times, whenever we have fever, low output, low hypovolemia, so the patients will be having the fever which is associated. And rarely athletes during the rest time. Okay, athletes are most of the time there is a high heartbeat, but when they are resting, they are also considered they will be having the physiological heart rate is decreased in these patients. And how can you treat these patients? Most of the time treat the underlying cause. Okay, after the fever you don't feel the sinus bradycardia, and if you see, if it is less than 60 beats per minute, if it is less than 60 beats per minute and the patient pulse is not palpable, okay, patient pulse is not palpable, then you have to consider the patient has to be treated immediately with the help of the IV atropine. Okay, IV atropine has to be given for the patient immediately. Next, sick sinus syndrome. What is mean by the sick sinus syndrome? Here you can see the patient is suddenly having the tachycardia, this phase, and immediately the patient is having the prolonged bradycardia. So okay, this is the prolonged bradycardia. So this multiple phases of the different tachybradyarrhythmias. Okay, so tachy and the bradyarrhythmias. So this is most commonly seen with the thyroid condition, a thyroid condition, or all the endocrinopathies. So for this patient, you have to treat the patient with the cause like thyroid. You can have to treat with the thyroid, and you have to give the calcium channel blockers to decrease the heart rate. But most of the times we use the beta blockers, but here the beta blockers is contraindicated. Beta blockers are contraindicated. Next, moving on to the degree blocks. These degree blocks are very important. So first degree block, what is happening in the first degree block? So first degree block, what happening here, the 1 p wave and the per qrs complexes. Okay, so 1 p wave qrs complex, 1 p wave qrs complex, 1 p qrs complex. But what is happening here? So the PR interval, which should be less than 20 seconds, it is normal, but here it is more than 20 seconds and more than 25 seconds, more than 30 seconds. So this is prolonging. So first degree heart block, so the patient will be having the PR prolongation. Okay, PR prolongation, and treatment is, if it is more prolonged, you can go and give for the patient atropine has to be given for this patient. Next, second degree heart block. Second degree heart block is known as a Fmge heart block or the Mobitz type 1. So in this patients it is opposite to that, so there is a PR prolongation, there is a PR prolongation. Along with that, P wave is dropped. Okay, so here you can see prolonged, prolonged, sudden drop, prolonged, prolonged, sudden drop. So this is what's seen in the second degree heart block. So here also treatment will be mostly atropine or underlying cause has to be treated. Next, second degree heart block. In the patients with the second degree heart block, we are going to use the uh, differentiate from the first second degree of the Mobitz type 1. How we are going to differentiate? So here the P waves is not going to be dropped. So P waves is present and the PR interval is normal. Okay, it is less than 20 seconds only. But here there is a QRS complex that is dropped. Okay, QRS complex is dropped. See, there is no difference in the interval, but suddenly there is a QRS complex is missing here. That is what seen in the second degree, that is Mobitz type 2. Next, third degree heart block. In the third degree heart block, it is completely different. So P waves, here you can see they're actually different, completely different P waves and also QRS complexes. They're not even like a seeing each other. So this is what's seen as a complete discrepancy. Okay, complete discrepancy between the P, P wave and also QRS complex. So this is we consider as a severe bradycardia, and these patients has to be treated with pacemaker. Okay, most of the times the patients may have ultimately the patient may die due to this arrhythmias. Next, moving on to the tachyarrhythmias. Tachyarrhythmias will be depends on the QRS complex, how the QRS complex is present. For example, let's say the QRS complex is the normal QRS complex is around the 100 seconds. Okay, around the 100 seconds, 100 milliseconds. Okay, 100 milliseconds. But we are having the tachyarrhythmias, that means more than 120, right? More than 120. So there will be QRS complex which is narrow, okay, less than 120 milliseconds, or it is broad, more than 120 milliseconds. So narrow is actually coming from the atrium. So either it could be pathology associated with the P wave, or completely the P wave is absent. P wave is present, P wave is absent. Next, broad QRS complexes means wider QRS complexes means these are coming from the ventricles. So we have V fib and the V tachycardia. So P wave is present, it is sinus tachycardia, okay, or the atrial tachycardia. And P wave is absent, that is the atrial fibrillation or the supraventricular tachycardia that is present. And the A tachycardia also have the subtypes that we will be discussing later. Here you can see. So we have the two, sinus tachycardia and the atrial tachycardia. So how these both are concerned and important, how we are going to differentiate this both. So let's see. So sinus tachycardia is most common in this. This is the most common. And sinus tachycardia, if you can observe, this is at the same phase only. So there is no difference in the sinus tachycardia. So this is the narrow QRS complex. Same as here also, this is also having the narrow QRS complexes. P waves are equal to number of QRS complexes, but here more P waves than the QRS complexes. The pathology itself, atria will produce more contractions. That is what P waves. And here we can treat the patients with a supportive and treat the underlying cause, but you have to differentiate here a flutter or the patient is suffering from the multi-atrial tachycardia and treat them. Okay, treat the other pathologies that is associated. What is atrial fibrillation? Atrial fibrillation is the most common overall all tachyarrhythmias. Okay, all the tachyarrhythmias, and this is most common in adults. Right? What is happening here? If you can observe, just look at this. So the patient is having more than 120 beats, right? And each of them is having the different length. Okay, if you can observe, each of them having a different length. So the rate is high and same as the rhythm is high. But is the rhythm is in the regular phase? No. So the rhythm is irregular. So this is how the patients with the atrial fibrillation will be presented. But these patients, P wave, can you differentiate where is the P wave? Okay, we can't differentiate, right? P wave is not seen. So P wave is absent. This is the most differentiating. Irregular rhythm with the P wave is absent, that is the atrial fibrillation. How you are going to treat depends on the patient situation. If the patient is having the low BP or the hemodynamic status is not working properly, then we can go for the cardio version. But most of the time we don't prefer the cardio version because atrial fibrillation, what happening? The atrial contraction is not happening. So the blood is pooling here. Okay, whenever there is a blood pooling, there is a high chance thrombosis is formed. So if this thrombosis, this clot is dislodged, it can cause the CVA, it can cause the MI. Okay, it can cause the MI or it can cause the DVT or pulmonary embolism. So all this considering the facts, we are not going to treat the patient most of the times cardioversion. We actually go for the stabilizing the patient first and then go for the echocardiography. In the echocardiography, if you see the clots, you are going to start the patient on the dual antiplatelets therapy. Okay, dual antiplatelets therapy that you are going to add. If there is a no clots, okay, if there is a no clots, then you can start the patients on the amiodarone. Okay, amiodarone is a safe for almost all the arrhythmias that you can use. Next, moving on to the atrial flutter. Atrial flutter is a type of atrial tachycardia. Okay, this is a type of atrial tachycardia. But these patients will be having this sawtooth appearances. This sawtooth appearances. But is the P wave is present here? Yes, P wave is present, but we cannot differentiate. That is the difference. So P wave is present. Is it the regular rhythm? Yes, this is the regular rhythm that is present. So also known as a sine wave pattern or the sine tooth pattern. Again, depends on the patient. Is the patient is stable? If the patient is stable, then just give the beta blockers to decrease the heart rate. If the patient is unstable, that means BP is fluctuating, then what we have to do for this patient is the cardioversion. Cardioversion has to be done. Next, tachycardia. So, supraventricular tachycardia that we are looking here. So, supraventricular tachycardia, the most common supraventricular tachycardia is present in the patients of the children. Okay, most of the children will be having this condition. So, paroxysmal supraventricular tachycardia, this is also narrow QRS complex, right? This is also narrow QRS complex, but interval is same. All interval is same only. 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4. So the interval is same. So rhythm that is we are looking at here is a regular rhythm and the rate is raised. But again, can you differentiate the P wave? No. So can you differentiate the P wave? No. So the P wave is absent. So my diagnosis from the atrial fibrillation, and here only the differentiating feature is a regular. Atrial fibrillation is a irregular, but here it is a regular rhythm. That is what paroxysmal supraventricular tachycardia. And how you are going to treat these patients depends again on the patient's presentation. If the patient is stable, then we can go for the vagal maneuvers. Okay, vagal maneuvers. If vagal maneuvers are not decreasing the pain, then we can go for the IV adenosine. It's the best drug. It has only 10 seconds of the half-life. You have to give immediately. That is IV adenosine. But adenosine can trigger the asthma. So if the asthma patient is there, in this patients, I am not going to give the adenosine. So for this patient, I can give the IV verapamil. Okay, IV verapamil is given for the asthma patients. Remaining most of the patients, IV adenosine can be decreased. But unfortunately, the patient is unstable. So again, you are going to go for the cardio version. All right. So next, moving on to the multifocal atrial tachycardia. The name itself telling it is a multifocal, different types. Atrial means it is a P wave. Okay, P wave is present here, but it have the different features. It is downslope, it is bifocal or bifid, or it is a V shape. So all different shapes, if you can see, that is known as a multifocal atrial tachycardia. How many multifocals that you have to see? At least more than three. Okay, at least more than three P waves pattern is seen with the tachycardia, that is considered as a multifocal atrial tachycardia. If the patient is stable, please give the beta blockers for the patient. If the patient is unstable, you have to treat the patient cardioversion. Cardioversion has to be treated. And this is most commonly seen in the severe COPD findings and the drug theophylline. This can also cause the multifocal atrial tachycardia that we are going to see. Next, ventricular tachycardia. The ventricular tachycardia, what we discussed, guys, there is a wide or the broad QRS complexes. Broad QRS complexes. This is the broad QRS complex that we are looking at. So we have to look for how we have to treat these patients. So ventricular tachycardia, if the patient is pulse is present, okay, patient is stable, then you can give the amiodarone and you have to monitor the patient every minute. But patient is having ventricular tachycardia, pulse is not present, patient is unstable, again, cardioversion. No, the ventricular tachycardia is not cardioversion. It is the defibrillator. It is a defibrillator that you have to give for this patient. Very rarely, The patient is having the ventricular tachycardia, pulse is present. Most of the times there will be having the pulseless only. But if the pulse is present and unstable, if you don't find the defibrillator, then you can go for the cardio version. But most of the times the scenarios will be pulse is present or the pulse is not present. So this is how we are going to differentiate the ventricular tachycardia. Next, ventricular fibrillation. Ventricular fibrillation, if you can observe, you cannot see differentiation between the P wave, QRS complex, any segments, any intervals. So this is disorganized type. Okay, very much this is a disorganized type. So in this disorganized types, always go for the defibrillation. Whether the patient is stable or unstable, they can eventually die within the minutes. So that's why we have to go for the defibrillation for these patients, regardless of the patient's status. Next, torsades de pointus. Torsades de pointus is mostly due to the QT interval increased. So this patient is having the QT interval. So that is prolonged. And for this patients, the drug of the choice is Fmge if they are stable. And if they are unstable, then again we have to go for the cardio version for this patient who is unstable. But what are the causes that you have to remember this QRS complexes? We have A, B, C, D. So A for anti-arrhythmic drugs, the classes are 1A, 1C and 3. These are the classes that can cause quinidine and also prokinamide, all these drugs which will be causing. Next, B. B for biotics, antibiotics and C for antipsychotics. Antipsychotics like uh, the drugs like haloperidol, all these drugs will be can also cause. Next, D for depressants and D for domperidone. Domperidone. All these drugs can increase the patients with the torsades de pointus. Next condition. These are the two important conditions that you have to take note. Wolff-Parkinson's-White syndrome and also Lorn-Gannock-Levin syndrome. What happening in the patients of the Wolff-Parkinson syndromes? For example, SA node, AV node, bundle of his, bundle branches. But this is giving the extra wave, okay, the extra conduction. Here you can see this is known as a extra conduction, or we also call this as a bundle of Kent. This is known as a bundle of Kent. So this bundle of Kent is uh, immaturely going on. So it is immaturely or the prematurely it is giving the conduction. So that's why the patients will be having the short PR interval, and this wave, this is known as a delta wave. Delta wave with a short PR interval that is seen in this patients. Okay. Eventually, what we have to do for this patient, the treatment of the choice is the ablation. You just remove this entire bundle of extra Kent that is present. Okay. If the patient need any drugs, then we can go for the prokinamide. Okay, prokinamide is in the acute stages. We can help for this patient. Next, Lorn-Gannock-Levin syndrome. So here you can see this is a Lorn-Gannock-Levin syndrome. So what is happening in the Lorn-Gannock syndrome? So let's see here. So the waves has to be passed SA node to the AV node, right? But there is an extra wave that is present just nearby the atrium, atrium of the bundle of his. So this extra wave which is going to give, that will also again give us the PR interval shortening, but here the delta wave is absent, similar only, but the bundle of Kent is here. It is having the extra bundle that is just nearby the interventricular septum, and the treatment is again here also we have to do the ablation for this patient. Okay, this, here you can see there is a short PR interval, but there is no bundle of Kent is present. Next, what is the U waves? Where you are going to see the U waves. Most of the times U waves are normal. Okay, it is considered as a normal. Pregnancy patients, children, and even the athletes, they are going to have always. What is happening normal in them? What is not in the others? Because in the most of the patients, it is a papillary contraction. It's a simply papillary contraction inside only. Okay, but if it is abnormal, only in the patients of the hypothermia. Okay, and also patients who is having the low calcium, low magnesium, these patients also will be having this condition. Just you have to treat the underlying cause. Next, J point. What is the importance of the J points? So J point is going to important for us to differentiate this ST segment. Okay, so ST segment is started at this point, so that is known as a J point. And why J point is important? It will tell us ST elevation, it will tell us ST depression, depends on the J wave pattern. Okay, that is how we are going to differentiate. Next, we also have the another picture that you can see. This is the Osborne wave. So there is no ST segment. Okay, ST segment is absent in the Osborne wave. So that is what ST waves that is going to see. And mostly this is also present in the patients with the fever. Okay, rather than you can choose the hypothermia. Fever patients we will see, but the hypothermia is more commonly seen. So that is the Osborne waves. And this is not SR interval. So ST interval. So for example, if you see, this is the waves. Okay, this is the ST elevation. I can understand. But here, this is not a ST elevation. Okay, this is known as a Osborne waves. These are Osborne waves. Next, moving on to the hypokalemia features and the hyperkalemia features. In the patients of the, so this is the hyper, this is the hypo. So let's see, hyperkalemia. More and more potassium is present in our body. So we will be having T waves, that is tall. Okay, tall T waves. Okay, sometimes there is a ST depression or the ST elevation. ST elevation, right? Next, QRS complex is widened. QRS complex is widened, right? Next, PR prolonged. And the coming back to the hypokalemia, low potassium. So we are going to see T wave is flattened, T wave is flattened, U wave is present, U wave is present, or the ST elevation is not seen here. Next, the QT, again here it is prolonged, same as the PR is prolonged. Same as PR is prolonged. How we are going to differentiate, sorry, how we are going to treat these patients. So here we can treat with a calcium gluconate. So differentiation is depends on the patient presentation and also the ECG waves. So here the treatment of this patient is the KCl, okay, potassium chloride. So this is how we are going to look after. Next, calcemia. So just a simple formula, calcium is always indirectly proportional to the QT interval. Indirectly proportional. That means hypocalcemia. So calcium is decreased. So obviously QT will be prolonged. Hypercalcemia. Hypercalcemia. So calcium is raised. So QT prolongation is decreased. So this is what we are going to see in the hypocalcemia and the hypercalcemia. So this is considered as a torsades. Patient can develop the torsades. Here there is no risk of torsades, but you have to treat the underlying causes of the each. That is what we are going to look. Digoxin toxicity. So digoxin toxicity, what is the mechanism of the digoxin? Mechanism of the digoxin is sodium potassium pump that is completely blocked. So the sodium potassium pump is blocked in this patients. So that is the mechanism. Actually, the sodium will help the normal function. It is going to tell the potassium to exchange. So when the sodium potassium pump is not working, so this exchanger is also dysfunctioned. Okay, so calcium is not going outside. So what happened to the calcium if it is not go? Calcium can cause the contraction of the atria, right? Calcium inside is going to cause the atrial contraction. So the patients will be having the developing of the arrhythmia. We are going to see. What are the features that you are going to see? First, there will be the salivary slog, or scoop, salivary swab or the scoop, which is here. So this is the salivary swab or the scoop. So this pattern is known as a ST inversion or the ST depression, which is called as a famously salivary slope, or we can also say this is the scoop pattern. And PR interval is prolonged. PR interval is prolonged in this patients. QT is decreased. QT interval is decreased. So this is how the patients with the digoxin toxicity can be presented. So this we will not be leaving any ECG patterns that we had. All right. Next, coming to the ST elevation. In the ST elevation, we don't see the normal ST elevation as we discussed. This is the J point differentiating as the ST segment isoelectrical line. So how the patients will be having like SAD, okay, like this SAD, which is present in the T wave inversion. So this is a T wave inversion, this is the ST elevation and ST depression, T depression that you are going to see. So different patterns we are going to see. N STEMI patients, ST depression, N STEMI patients, T wave inversion, severe ST elevation, that is going to be STEMI patients that you are going to see. But the one point that you have to differentiate how the patients will be presented. So whoever is presenting with the ST elevated MI, this is a severe condition because necrosis might start if you don't treat early, right? But these two patients, non-STEMI elevations, this is still a warning that still you can do best and before the patient is going to have the irreversible damage that has to be taken care. How we are going to take care of this? So we will be discussing this in the module of the heart diseases. Okay, there we will be discussing how we are going to treat this condition. Okay, next, how the arteries that is involved. So here you can see we say this is the lateral, this is the anterior septal, and this is the right side, or this is the inferior. So sorry, so this is the inferior. Anterior septal is this is the inferior, this is the lateral, and here it is the right side pattern. So whenever, if you can observe here, the arteries that is bifurcated from the aortic sinus, it is bifurcated into the right side branches and the left side branches. So the main left anterior branch is the LADA, and the left circumflex, that is the lateral one, and the right side artery is the right coronary artery. So this is how we have branches is present. Okay, in the broader picture, if you can observe, this is the right coronary artery, this is the left coronary artery, and the left coronary artery is giving the marginal artery, circumflex artery, and also anterior interventricular artery. So right side of the artery, which will be giving the right marginal artery and posterior interventricular artery, sinus artery, or also SA node artery, and the AV node artery is given by the right coronary artery. So how, why this is important for us? Because it will tell us where the heart is having the problem. So, okay, where the heart is having the problem. If you see the lateral sides, left circumflex artery. See the left circumflex artery on the lateral side. Next, right side. Here it is the right side. So most of the times right side is right coronary artery. Right? This is the right coronary artery that is blocked. Next, inferior waves. So inferior is also actually coming from the right coronary artery only. So this is also involves the right coronary artery. All right. Next, lateral LCA. Next, anterior septal. So this is the anterior septal. So this anterior septal is actually running by the LADA. So this artery name is the LADA. And here also LCA. So this is how the lateral waves, inferior waves is going to be affected in this patients, right? Next, moving on to the next picture. Here you can see, so the patient is having the diffuse MI, okay? I mean diffuse ST elevation. Every wave, if you observe, ST is elevated. Can this be the MI? No, this is not a MI. So this diffuse MI or the diffuse MI changes is seen in the patients of the pericarditis. This is seen in the patients of the pericarditis we are going to see, and that is differentiated in the four stages: stage 1, stage 2, stage 3, and the stage 4. So in the stage 1, we are looking at the PR depression first, in the most of the times, and there is a generalized ST elevation which will be seen. Next, coming back to the transitional, where the patient is recovering so far, and after that there is a T wave inversion and normalization of the ECG which will be seen in the fourth stage. So these are the points that you have to recall, guys, at least very high yield for your examination. I think this video is very lengthy, but still these topics are frequently asked topics. So please do revise and read these topics. And those who are new to this channel, please do subscribe and share with your friends. And stay tuned for the last subjects like PSM, Optal, ENT, and the OB-GYN. That is also very important. And stay tuned for the Sureshot series. And don't forget to subscribe, guys. And do like and share with your friends once again. And also, please watch remaining videos also. That will be helpful for your examination. So until then, see you guys. Happy preparation.